will be in the other YouTube and other channels.
That is such amazing number, sir. It's a great number.
Hello.
How many numbers? How many people?
4,000, nearing 4,000. So.
Oh, fantastic.
So in this group, we have 570 already. So, so this group will get filled up first. The rest of the channels will be live soon.
That includes the YouTube also, no? Everything.
Yeah, all put together around 4,000, sir.
4,000.
Hi, Shruti. Madhavan.
Oh, sir.
Hello.
Good afternoon, sir. How are you? Satyan, sir, good afternoon.
Good afternoon. Good afternoon, Mohan Rajan, sir. Nirmal, sir.
Good afternoon.
Tangwell, sir.
Good afternoon.
Good afternoon, sir.
Good afternoon. Good afternoon.
Madam, good afternoon.
Good afternoon.
Hello, how are you?
Good afternoon, Satyan.
Good afternoon, sir.
Good afternoon. Good afternoon. How are you?
Fine, sir. Fine, sir.
Tangavel, sir. Good afternoon.
Good afternoon. Ravi Kumar.
Madhavan, sir. Good afternoon.
Good afternoon. Good afternoon.
Sir, Ravi Kumar, good afternoon, sir.
Good afternoon, sir. Good afternoon.
Kaushal, bro. Good afternoon.
Hi, Kaushal.
And எல்லாரும் கோயம்புத்தூர் group.
No, TNOA group. இப்போ வந்துட்டு AUS groupனு சொல்லணும்.
Mohan Rajan, sir.
அப்ப நான் தான் odd man out.
The leader, odd man out.
Ravi Kumar, sir, can we start?
Yes, sir, please, sir.
Okay, sir. Good afternoon, everyone. I'm Dr. Nirmal Frederick, Chairman of the Academy of Medical Specialties of IMA Tamil Nadu. Respected President-elect Dr. A.K. Ravi Kumar, our President Sridhar sir will be joining us soon. The senior leaders of IMA, our AMS office bearers, Dr. Sendil Kumar, the dynamic secretary, who is also the organizing secretary of this Tamil Nadu Amscon, and Dr. Mohammad Ibrahim, joint secretary, and our team from All India Ophthalmic Society and Tamil Nadu Ophthalmic Association, the ever dynamic Dr. Mohan Rajan, President-elect of All India Ophthalmological Society.
Thank you.
Keynote speaker for this evening, and also our chairperson for this afternoon session, Dr. V. Thangavelu, Dr. V. Madhavan, who happened to be a birthday boy today. On behalf of everyone, happy birthday, Madhavan sir. And convener Dr. J. Sendil Kumar, and all the faculty, ophthalmic faculty here, a warm welcome to all of you. And all the colleagues and friends who have joined this ophthalmology track of Amscon, welcome all of you. So very, very warm welcome. As chairman of the AMS wing, it gives me great pleasure to welcome each one of you. The Academy of Medical Specialties was created for exactly an afternoon like this, where specialists come together, not to talk about the eye in isolation, but to place it where it truly belongs, at the crossroads of the whole patient. So this is the thread running through our 3 sessions today. We begin with ocular emergencies and red flags, of course, with the keynote address on eye and systemic medicine. The signs no clinician can afford to miss. We then turn to the everyday epidemics, dry eye, myopia, and glaucoma, the condition we see every single day and must never treat casually. And we close the session with eye and the body, where drug interaction and diabetic retinopathy remind us that eye is often the first window into systemic disease. So we have 7 focused talks, and all sharp and practical from faculty who are experts in their own right, who brings real clinical wisdom to each topic. I'm sure this afternoon session would be an enlightening and informative one for all our delegates who has joined us in large numbers Thank you all for your wonderful support. In the last 2 days have been wonderful. The infectious disease session and yesterday the pulmonology session, thanks to Dr. Jayaram, who is also the Vice President-elect. So to our faculty, all 6 of you, thank you for your time and sharing your expertise generously with our delegates. And to all our delegates, please engage. Question, if you have any questions, please put in the chat box or unmute yourself. And maybe we'll have after 2 talks, 5 to 10 minutes question and answer sessions, so that you can take something back to your clinic tomorrow morning. So with that, I welcome all of you for this ophthalmology track and request our President-elect Dr. A.K. Ravikumar to deliver his address.
Thank you so much, sir. It's indeed a great pleasure to be amongst the visionaries, the ophthalmologists. I'm very happy to be with you all today. And indeed, the idea of having this AMS wing by itself in IMA is to create the basic awareness and also what, as a clinician, we should know. We should not confine ourselves exclusively only to our specialty. We should know something about all the specialties. That is the basic. And as AMS, the topics which has been selected for this conference in general is fantastic. Actually, I should appreciate the office bearers for selecting the topics.
Sir, your screen is not visible, sir.
Sorry, it got disconnected.
Yes, sir.
Hope
Now you're
I'm
visible,
audible.
sir. Yes. Yes, sir.
Afraid to touch the eye. If a patient comes with red eye, we usually get astonished and we don't see into the eye at all, and we immediately refer the patient to the ophthalmologist. But as a physician, as a basic physician, we should know the red flag signs of the eye, and we should know when to refer. Is it an emergency? We have to find it out. We should know. So these practical things are very much needed. I am very happy that you have such topics, and invariably the headache, patient will come with the headache, but we may not know whether it is because of the headache is because of the eye signs. And most of the times what we see in the clinic is patient will come with a foreign body in the eye. So how to handle that foreign body in the eye? Should we immediately refer to the ophthalmologist or do some basic first aid and then refer to the ophthalmologist? By the time the patient comes, he would have just scratched the eye and he himself would have done some damage to the eye and all. So these basic parameters, what we should do, what we should not do, all those things, I think today's conference will give the idea to all our fraternities who have joined this. And my request to all the delegates is don't confine yourself to the topics which are being talked about today. Whatever practical difficulties which you would have faced during your practice, you can just ask the experts here. It's a very rare situation where you will get all the experts in a single podium today, so that you can clear your doubts, and then we can, because the vision is most important. If anything happens to the vision, legally also you will be under sue, and it is our bound duty that we handle the eyes very carefully. So very nice. I am very happy that the AMS is doing a wonderful job. Hats off to you all. Let the sessions be very useful and fruitful. Thank you very much. Thank you.
Yeah. Thank you, sir.
Thanks.
Unmute, Nirmal.
Sandil, do you have any update from the AMS for the delegates?
Sir, nothing. So we can proceed, sir.
Okay.
Yes, sir. We can
Anna,
proceed to sir.
I'll share my screen and introduce the panelist. Is my screen visible?
Visible.
Okay. So this is the AMS conference 2026 at a glance. We started on July 14th with vaccination and infectious disease. And yesterday we had a wonderful session on pulmonology, and today is day 3, ophthalmology track. Tomorrow we have fetal medicine and breast cancer. On the last day, we have the live and hybrid session on plastic surgery. So this is the entire event in one slide. So on day 3 ophthalmology track, we have with us Dr. V. Thangavelu, past president, Tamil Nadu Ophthalmic Association. To co-chair the session, we have Dr. V. Madhavan, Vice President TNOA and former Vice President of IMA West Zone. And we also have the PPLSS Chairman, Dr. J. Sendil Kumar, to be the convener for this session. So we have 7 talks today. So just to introduce the chairperson, Dr. V. Thangavelu, is the ophthalmologist, director of MB Eye Care Center, Coimbatore and Tirupur. He's also honorary consultant for Shankara Eye Center, actively involved in community ophthalmology since 1985, and has been a leader of great repute in IMA as well as ophthalmology, past president of Tamil Nadu Ophthalmic Association and past president of Indian Medical Association, Coimbatore branch. Welcome, Thangavelu sir. Happy to have you with us and share this session. We also have Dr. V. Madhavan, consultant Abhirami Eye Hospital and Vice President of Tamil Nadu Ophthalmic Association and past Vice President of IMA West Zone, Dr. V. Madhavan. Welcome, sir. We have the chap, Dr. J. Sendil Kumar, who runs Sendil Eye Clinic at Cheyyar, ophthalmologist and Executive Director of Sendil Eye Clinic. And he is an NABH assessor and currently the PPLSS chairman. So the man for all crisis. So welcome, Dr. Sandil.
Thank you, sir.
So we now start the proceedings with, I will introduce all the speakers and then we go to the keynote address. And we have the keynote address by none other than the Vice President, President-elect of All India Ophthalmic Society, the most dynamic and respected Dr. Mohan Rajan. He's the past president of TNOA and chairman of Rajan Eye Care and president of Shankara Nethralaya Alumni Association and past president of various associations, IARSI, TNOA and International Intraocular Club and chairman of the Eye Care of Rotary District. He has numerous achievements and awards to his credit, 2000 plus presentation. What is remembered and often he hits the scoreboard is with his IPL trophies, OPL trophies. I think 93 to date, Mohan.
Yeah, 93. Thank you.
93 and has 30 named oration, 52 publication and several numerous accolades. It's apt that he opens the innings for this AMS session ophthalmology track. Welcome, Dr. Mohan Rajan, and we are happy to have you with us today.
Thank you. Thank you very much, Nirmal. Thank you.
The next talk would be by Dr. Kavita Lakshmi, ophthalmologist and director at KKI and Pediatric Center, Tambaram, founder of Kanmani Vision Foundation, and past president of Tambaram Ophthalmic Society, and currently the managing committee member of TNOA, and past vice president of IMA Tambaram, a highly proficient cataract and refractive surgeon. She's been the instructor, speaker, and moderated various ophthalmic conferences, and winner of E.T. Selvam gold medal, and first to bring no touch, no flap technique to Tambaram. So, of South Chennai. So welcome, Dr. Kavita. Thank you for accepting our invite and happy to have you here part of this session. We also have Dr. Kalpana Suresh, Managing Director of Kalpana Eye Care, former professor and HOD, SRMC Koru, and visiting professor of ophthalmology, Rajan Eye Institute, and former president of IMA Koru branch, and teacher par excellence with so many awards and presentations, co-author of the CP Gupta Best Paper Award, and she's been the guide for many postgraduates, and also got the IRSA Gold Medal Award for Lifetime Achievement, and the SS Badrinath TNOA Salem Ophthalmic Gold Medal honored by TNOA. Welcome, Dr. Kalpana. Thank you for joining us today afternoon. When we have a dynamic youngster among us, to talk to us about the myopia epidemic, myopia surge, can we slow it down? Dr. Shruti Nishant is a pediatric ophthalmologist and neuro-ophthalmologist at MNI Hospital, Chennai. She's been the joint editor of TNOA Journal and reviewer for many other journals. And she also patent for Lumino Sundial, a wearable device. I think which she will be covering about this aspect. And she recently got the Travel Grant Award for the International Myopia Conference in Rotterdam 2022, has numerous presentations and publications. Thank you, Shruti, for joining us today. Welcome. And to cover the glaucoma, the silent thief, we have Dr. N. Satyan, past president of IMA Coimbatore, FSS district coordinator and past managing committee member of TNOA, currently the joint treasurer of TNOA, and is the director of Eye Trust Hospital, Coimbatore, a prolific glaucoma and cataract surgeon. So he would add a lot of expertise and information to this particular topic, glaucoma, the silent thief. Welcome, Dr. Satyan. The next topic is would be diabetic retinopathy. So we have Dr. Kaushal Ram, director of Ponnammal Doraisamy Eye Hospital. He is an ophthalmologist and also currently the president of IMA Coimbatore, one of the largest branch of IMA branches. He is a retina surgeon, so obviously he'll be covering about the diabetic retinopathy talk. He has accomplished a lot in this area, training so many retina surgeons and specialists in retina. We are together running a course called Diab Retina IMA under the aegis of AMS. If any of you are interested in joining diabetic retinopathy specialty course, kindly contact him. So this is a AMS certified course run in his hospital. And last, I'll be covering the two-way traffic, ocular effects of systemic drugs and systemic effects on eye drops. So this is one neglected topic because nowadays many people come with a long list of medicine polypharmacy, and they may have so many side effects that is reflecting on the systemic as well as ocular effect. I'll be covering those areas in my talks. So with this, I hand over the session to our chairperson and the convener. Over to you, Dr. Tangavelu, sir.
Good afternoon, everyone. It's nice to be with all the IMA and the ophthalmologists. Thanks to the Pollachi IMA for organizing this meet. Thanks to President IMA Tamil Nadu State Branch, Sridhar, who is an ophthalmologist, and Dr. A.K. Ravikumar, President-elect Tamil Nadu State Branch, National State IMA dignitaries, IMA friends for inviting the ophthalmologists here. A special welcome to Dr. Mohan Rajan, President-elect, past President TNOA, my colleagues, friends, Dr. Nirmal, past President TNOA, Madhavan, Vice President TNOA, Dr. Satyan, President IMA Coimbatore, Kaushal Ram, the present President of IMA Coimbatore, Dr. Kavita, Dr. Kalpana, Dr. Shruti, all of them are active members of both Indian Medical Association and ophthalmology. We ophthalmologists welcome our convener, Dr. Senthil Kumar, who is the PPLSS IMA Tamil Nadu State Branch. At present, there is an offer. I think we should all members who are not PPLSS or IMA State of the IMA, we should join this PPLSS, which is very beneficial for all our members. Welcome, Dr. Madhavan, who is chairing the session with me. He is starting the birthday with this. Today is his birthday. He's starting his birthday with a scientific program. Wish him many more happy returns of the day.
Many happy returns, Madhavan.
Many happy returns, Madhavan. It is really encouraging to note that more than 3,000 people have registered for this session. 3,000 doctors have registered for this prayer. This session will surely be an eye-opener for those from other specialties. The presenters are specialists in ophthalmology. They will give us a bird's eye view of how to collaborate to deliver the best comprehensive healthcare. Sir William Osler, one of the fathers of modern medicine, stated that the eyes are not only the window of the soul, but the mirror of health. When we examine a patient as a whole, listen to the patient. He is telling you the diagnosis, was the quote by William Osler. Even if the tongue hides, many a times patients don't tell us the history, the truth, but the eyes never fail to tell us the truth. If we look carefully, there is more than the eye, more than that meets the eye. In our practice, we do not willfully turn a blind eye to the subtle findings of the disease and treatment spectrum, but keep an eye on the patient's points conveyed today. We will definitely deliver appropriate treatment to save vision, life, comorbidities, as the Hippocratic Oath principle, first to no harm mandates. To set the ball rolling, I invite Professor Mohan Rajan, a very jovial, a very friendly person, philanthropist, human characteristic leader, charismatic leader with a scientific knowledge, meticulous cutting-edge skill, surgical skills, and a motivational leader. He is currently the president of the president-elect of the All India Ophthalmic Society. He was the past president of TNOA. He is a recipient of numerous national and international awards for his scientific work and philanthropic activities. The list of accomplishments is endless. We are eagerly waiting to listen to you to the modern ophthalmologic stance. Over to you, Dr. Mohan Rajan. We'll start with Dr. Mohan Rajan.
Can I share my screen, Thangavel?
Yes, Mohan, please go ahead. We're able to see you.
Able to see my screen?
Yes, sir. Loud
Yeah.
and clear.
Very good afternoon to all of you. And, able to hear me, I suppose.
Yes, sir.
At the outset, let me thank the IMA Pollachi for organizing this fantastic, this stellar program, I would say, with fantastic faculty. And this is a very, very unique program wherein every subspecialty in medicine and ophthalmology and ENT, whatever it has been covered. And today we have got exclusive ophthalmology. And a big thanks to Dr. Nirmal Frederick, chairman of the IMA Academy of Medical Specialties, who's been instrumental not only for IMA, but also for the Tamil Nadu Ophthalmic Association and also for the All India Ophthalmological Society. The All India Ophthalmological Society, the TNOA, can run without Mohan Rajan or anybody else, but not without Nirmal Frederick. He is the main pillar. I'm not exaggerating. He is the main pillar and the main person or the mainstay, I would say, as far as insurance problems are concerned, in TNOA as well as in the AOS, medico-legal problems are concerned, NABH problems are concerned. It's very rare to see such a personality wherein there is a 360-degree coverage in everything. And we are very fortunate to have our Nirmal Frederick in Tamil Nadu, in Chennai. And we are blessed that Dr. Nirmal Frederick is contributing in a big level to the All India Ophthalmological Society. I have to say this on this platform in IMA, as the president-elect of the All India Ophthalmological Society, that contribution and this thing from Dr. Nirmal Frederick is something which is incredible. My sincere thanks to Dr. Thangavel, my guru, mentor in Tamil Nadu Ophthalmic Association, a person known for his humility. Dr. Madhavan, Vice President, many happy returns. Dr. Madhavan, another guy who is I'm simply amazed by his humility. And all other my colleagues, President of the IMA, Dr. Sridhar, a very good friend of mine from Karaikudi, and he is also an ophthalmologist, a very dynamic guy. Dr. Ravi Kumar, another dynamic fellow from President-elect of the IMA. The IMA is actually a core which is working for the benefit of not only the ophthalmologists but also the practitioners across the entire Tamil Nadu. With these few words, I would like to start my topic. As you know, the eye is the window to the soul. Okay? The eye, that in the next maybe 15-20 minutes, I'll be talking on the different ocular manifestations, which is a physician, a general physician should know. All the ophthalmologists will know, but the general physician should know by a simple clue. These are my financial interests. Because this is a patient wherein the eye is the only place wherein the human body, where the blood vessels in the central nervous system can be examined directly. And that gives us a clue not only to the brain problems, but also to the problems in the body as well. So again, you can see this is the patient with the dry eye syndrome. Kalpana is going to talk about it. We have a dry eye patient. Always look at a systemic issue. For example, the patient can have a rheumatoid arthritis or a Sjogren's syndrome. As you know, it's an autoimmune disease, wherein the dryness of the eye is associated with the dryness of the mouth also. Diabetes mellitus, thyroid eye disease, and all these problems, systemic lupus erythematosus. So dry eye can be a manifestation of all these autoimmune problems which can be there. And dry eye is not uncommon nowadays. It's quite common, and more common than what you can imagine because of the gadget usage. I think Shruti is also going to talk about the myopia problem as well. This is a KF ring, as you know, is the ring which is there, copper deposited in the Descemet's membrane of the cornea. This KF ring is indicative of Wilson's disease, which is an hepatoencephalopathy can occur in these patients because of the copper deposition. And the KF ring is also very, very significant. Once you start the patient on penicillamine, the KF ring will completely disappear as well. Of some systemic issues like Marfan syndrome or any connective tissue disorder like Stickler syndrome or even homocystinuria for that matter. So the ectopia lentis, you cannot take it lightly. It can be a congenital ectopia lentis for which you don't have to do much. But when it's a Marfan syndrome, you have to look for the other factors. For example, the cardiovascular problems, the joint issues, the central nervous system problems, and all these things can occur. This is just to show you the ectopia lentis, autosomal dominant Marfan syndrome, and other systemic features include tall stature, arachnodactyly, and aortic root dilatation. And these patients are more common for the aortic aneurysms as well. Please understand this ectopia lentis can also be a feature of homocystinuria and many other conditions. The homocystinuria is more common than what you can imagine. And homocystinuria can not only produce ectopia lentis, can also produce multiple thromboembolic disorders, which I'll talk about a little later. Again, you can see this is the patient with the branch retinal vein occlusion, macular edema, hemorrhages. And this patient has got a homocysteine levels are very elevated.
Mohan sir, I think there is some connectivity issue. Maybe you can Mute
Mohan.
your audio and talk.
The slide is frozen.
Yeah. Things. I'll
Yeah.
call him.
Able to see? Are you able to see now?
Yeah, yes, sir. Yes,
Yes,
sir.
Yes,
Mohan.
sir.
We're able to see. Yeah.
No, my connection got cut in between. Sorry about it. So
Yes,
this
sir.
is a quickly go through it. Again, you
Continue.
can see Nirmal is going to talk about this. This is a very common problem which you are facing every day. Almost every patient, either they are on blood thinners, which is not a very major issue for cataract surgery, but when they are on patients like when they are drugs like Urimax or tamsulosin, what happens is there is an alpha adrenergic receptor blocker, which is used for benign prostatic hypertrophy. And this produces severe problems in the pupil, that is the iris. The iris starts misbehaving during the surgery. Are you able to hear me now?
Yes, sir.
Yeah. Acute
Yes,
anterior
Mohan.
uveitis. Yes, ankylosing spondylitis, reactive arthritis, psoriatic arthritis, inflammatory bowel disease. All these problems can occur. So, the anterior uveitis may be a manifestation of some systemic issue as well. And we have what you call a uveitis workup for all these patients. And this uveitis workup includes even the autoimmune workup as well. And also for HLA B27, B5, which is again very important for you to understand. Again, this patient has got a diabetic retinopathy. Kosal Ram is going to talk about it, which is becoming a very major issue. And more than 100 people, a million people are diabetic in our country, out of which approximately 20-25 million people will have diabetic retinopathy. Diabetic retinopathy have got 4 stages, stage 1, 2, 3, and 4. And I'm not going to talk about it, but more importantly, please understand, as physicians, this is a very, very important, it's like a time bomb. And make sure that as soon as a patient is diagnosed to have diabetes, send the patient to an ophthalmologist so that the diabetic retinopathy is ruled out right away, because we do not know how long he's been having diabetes before that. Normally, we see many times we see patients who come in the advanced stage 3, stage 4, advanced diabetic disease, high risk proliferative diabetic retinopathy. And this is again a very major issue for us to understand. And we can early stages of diabetic retinopathy, non-proliferative diabetic, we can completely reverse it. It's not only the control of diabetes, as physicians know better than ophthalmologists. It's a control of the other associated factors like hypertension, kidney disease, anemia, dyslipidemia, that is taking care of the cholesterol, triglycerides, and making sure the patient does not resort to any smoking or alcohol. And all these factors can aggravate the diabetic retinopathy as well. And the ophthalmologist has to have a complete connection with the physician and the diabetologist to make sure that the patient does not become blind due to diabetic retinopathy. This is an advanced diabetic retinopathy, or what we call as stage 4 advanced diabetic eye disease, wherein you can see there's a traction retinal detachment involving the entire posterior pole as well. You can see this is again a patient with a third cranial nerve palsy. Cranial palsy, there are 3 nerves which connect the eye with the brain: third nerve, fourth nerve, and the 6th nerve. The third cranial nerve palsy is not uncommon, especially in patients who got diabetes. So always when you have a third cranial nerve palsy, ask for an MRI and an MRA. in these patients to rule out any space occupying lesions or a posterior communicating artery aneurysm, which can result in an acute third nerve palsy as well. If it's a chronic, if it's what do you call painless third nerve palsy, then you always look for the diabetes, uncontrolled diabetes, or even systemic problems like hypertension also. This is a patient with a central retinal artery occlusion. As you know, the central retinal artery is a branch of the ophthalmic artery. When the central retinal artery occlusion, always look for any cardiovascular problems. More importantly, any carotid occlusive vascular disease, or any patient who's got a hypercoagulable status or homocystinuria. In younger patients, always look for antiphospholipid antibody syndrome. And all these factors, older patients look for any carotid artery stenosis or occlusive disease, and of course, cardiovascular problems as well. And this can occur as an emergency when you have a central retinal artery occlusion. And they can have sudden drop in the vision also like this. And this is a ciliaretinal artery sparing outflow. This is again, when you see everything red on the retina,
And the connection is lost.
Yeah, I
Mohan.
think,
Oh, some problem.
Mohan sir, you can close your video and only the audio would be better. I'll call
அவங்களோட
him.
வீடியோலாம் போடாம என்ன பிரயோஜனம் ஐயா? மோகன் ராஜன் ஒரு பெரிய ஆள், அவர் பேசுறாரு ஆப்தல்மாலஜில. அவர் வீடியோ போடாம ஆடியோ மாத்திரம் பண்ணுறாங்களாம். வீடியோ படம் பண்ணலன்னா நல்லா தெரியும். ஏதாவது தெரியும்.
Mohan sir, we lost your audio. Slides are moving, but can't hear your.
Okay. Now about it.
Yeah, now, okay.
Sorry, ma. Sorry about it. So again, you can see this is the patient with the, I'm very sorry, Nirmal, you're able to hear me?
Yes, sir, we are able to hear you. You can go back on 2 or 3 slides.
Now?
Yeah, central retinal artery.
Any
Yes.
retinal vein occlusion, again, look for younger patients, always look for autoimmune disease or any inflammatory etiology as well. Combined central retinal artery and vein occlusion, again, look for autoimmune pathology in younger patients, antiphospholipid antibody syndrome, homocystinuria. Again, this patient, you can see here, this is a malignant hypertension, and this is malignant hypertension is a stage 4 hypertensive retinopathy. And you can see here there's a papilledema and also macular star problem. And this can lead to either any kidney disease. And this particular patient had a renal artery stenosis also. So always look for this. You can see here, this again a patient with a hypertensive retinopathy. The hypertensive emergency characterized by elevation of blood pressure. When the hypertensive retinopathy can be significant, can have a problem in the retina, can have a problem in the kidney. Always look for any cardiovascular problems as well. This hypertensive retinopathy is a very, very serious issue. And you can see this is a patient with a mixed retinopathy, both the diabetic retinopathy and hypertensive retinopathy. And these are all patients who have got some microangiopathy throughout the body. These are all chronic diabetics and hypertensives, and they also have other problems as well, arteriosclerosis and other problems. Ocular ischemic syndrome, we see this of late a little more commonly because we are looking for it. When the patient has got a fairly featureless retina and severe rubiosis, that is iris, that is neovascularization of the iris. And the angiogram, you can see there's a lot of the capillary dropout also in the fluorescent angiogram. And this is an indication of an ocular ischemic syndrome. And this patient can be completely saved by doing an aggressive pan-retinal photocoagulation. But look for always a carotid occlusive vascular disease. You can see here this particular patient. We had to look for a carotid atherosclerosis, plaques in the carotid, and always refer the patient to the vascular surgeon or the cardiovascular surgeon or the cardiologist to make sure the patient does not have any carotid occlusive vascular disease as well. This is again anterior ischemic optic neuropathy, AION. The AION is a condition wherein there is a decrease in the blood supply to the optic nerve. And this usually occurs in older patients, secondary to hypertension, secondary to some other vascular disorders, very rarely due to hypertension, due to diabetes also. And this AA1 can be either ischemic or non-ischemic optic neuropathy. And usually the non-ischemic, they respond fairly well to steroids as well. These are angioid streaks. These are breaks in the Brooks membrane. The Brooks membrane are the layer underneath the retina and the choroid, and underneath the choroid the Brooks membrane is there. And there's a breaks in the Brooks membrane, which is indicative of some systemic issue like pseudoxanthoma elasticum or osteogenesis imperfecta or Ehlers-Danlos syndrome or Marfan syndrome, and all these can be using. And this Brooks membrane can be associated with the choroidal neovascular membrane. And this patient has got a scleritis, and scleritis is usually autoimmune disorders. And this scleritis patients can come with a severe pain, redness, and they can have unbearable pain, which is very, very typical. And these patients normally require steroids and followed by immunosuppression as well. You can see this is a patient again with the rheumatoid arthritis, acute anterior uveitis, peripheral ulcerative keratitis, scleritis, and all these are manifestations, can be manifestations of rheumatoid arthritis or any autoimmune disease for that matter also. Again, a patient with sarcoidosis, you can see multisystem granulomatous disorder of unknown etiology. Again, you can see this because sarcoidosis and tuberculosis need to differentiate. Because sarcoidosis, the treatment is steroids, the tuberculosis treatment is anti-tuberculosis treatment as well. Retinal periphlebitis with candle wax drippings can also occur. Again, ocular myasthenia, patient coming with the ptosis. Many times, you diagnose as aponeurotic ptosis, and this is one again a very, very major issue we can understand. This ocular myasthenia or the myasthenia can be secondary to the myasthenia gravis, which is there in the general affecting even the respiratory system as well. And this patient, we had to do came with the ptosis, which has had a variable, you can see the ice pack test. After the ice pack, the ptosis improved because acetylcholine gets less destroyed with the ice pack. And we did a CT scan of the chest and we found out the patient has got thymoma. Once they removed the thymoma, the myasthenia, ocular myasthenia also completely reversed as well. So this is again very important. When a patient comes with the ptosis, it's very important for you to understand this. Thyroid ophthalmopathy, I know thyroid eye disease is more common than what you can imagine. The thyroid eye disease can occur in patients usually with hyperthyroidism or Graves' disease, can also occur with hypothyroidism or even with the euthyroid. It's an autoimmune disease, and you can see thyroid eye disease when can be bilateral or unilateral proptosis. There can be thickening of the muscles and inflammation in and around the eyeball, that is in the orbit as well also. And I usually do an MRI to find out any thickening of the thing. This is again a compressive optic neuropathy, secondary to the autoinflammatory inflammation or idiopathic orbital inflammation, or even for the thyroid eye disease as well. Again, this is a patient, this is syphilitic retinopathy. A syphilitic retinopathy, typical leopard lesion, a leopard spotting. And the syphilitic retinopathy, again, we have seen this. We never saw this about 10, 15 years seeing again of late we are seeing the syphilitic retinopathy more commonly than what you can understand. And this syphilitic retinopathy can occur in patients. You can see this is a patient who came all the way from Gurgaon to us, and they were not able to diagnose. And then we found out syphilitic retinopathy, and we gave her the intravenous aqueous crystalline penicillin, and for 10 to 15 days, and completely reversed the syphilitic retinopathy also. You can see the walk or VKH syndrome, walk Koyanagi-Harada syndrome, and the the neurological symptoms, bilateral uveitis. They can have vitiligo, they can have headache, they can have problems in the hearing, and all these problems can occur. They can have exudative detachment of the retina, there can be inflammation in the retina, and they respond usually to IV methylprednisolone followed by oral steroids and subsequently with the immunosuppressants as well. Ocular tuberculosis. Tuberculosis, many people, physicians think that tuberculosis can occur only if the systemic issue. Many times, it can affect only the eye, the ocular tuberculosis. These are serpiginous like choroiditis, characteristic finding in ocular tuberculosis. And patients with tuberculosis retinal vasculitis often present with occlusive disease and perivascular choroiditis scars as well. You can see here on this picture. Again, you can see here ocular tuberculosis. This is a patient where they were in the healed macular choroiditis lesions, and these patients respond very, very well to the anti-tuberculous. We start with the anti-tuberculous, followed by the oral steroids under cover of the anti-tuberculous treatment also. And these patients have to be differentiated from other forms of the inflammatory thing, and because ocular tuberculosis can be a very major problem which can occur. Okay, toxoplasmosis, I know acute toxoplasmosis lesion, and this can occur chorioretinitis with hydrocephalus, intracranial calcifications. This is a toxoplasmosis scar, which is a typical punched out scar in the macula, which can occur either because of congenital toxoplasmosis or acquired toxoplasmosis again. And this is again the pizza in the pie appearance. The patients who got a CME retinitis, and this patient had an HIV positive, and and we had to treat with the heart treatment for this patient, and the patient completely reversed. We had to give intravitreal ganciclovir also for this patient. Again, herpes zoster ophthalmicus can occur not only involve the trigeminal nerve, but also involve the retina also. The varicella zoster can affect the retina also and produce what is called an acute retinal necrosis, which you can see in this particular slide. Optic neuritis, as you know, this patient has got optic neuritis, swelling of the optic nerve. Unilateral or bilateral sudden drop in the vision in younger patients. Always look for an optic neuritis in these patients. And always look for a neuroimaging. The neuroimaging should consist of not only an MRI of the brain and orbit, but also spinal screening, because you can miss a condition called Devick's disease, which is a neuromyelitis optica. And these patients, we have to go for the complete the antibodies also. Again, papilledema, as you know, papilledema can be secondary to malignant hypertension, as I told you. But papilledema like this particular patient came all the way from Delhi, and they were not able to diagnose. He just came for a routine checkup, transient blurring of vision, found both eyes papilledema, cross papilledema, 6/6 vision without any problem. But you can see the fields were also normal. But you can see when we did an MRI, there was a huge cerebellar tumor. And the cerebellar tumor probably responsible for the papilledema. Immediately, very next day, was got operated with cerebellar tumor, and the papilledema completely regressed as well. Optic atrophy can be either unilateral or primary optic atrophy, unilateral, bilateral. And this can be secondary to some problems in the brain also. And this can also be secondary to toxic amblyopia, the toxic or the alcoholic or methanol-induced optic neuropathy also. And this is a very interesting case. You can see the myelinated nerve fibers on the optic nerve. And this patient came 1 year later and completely disappeared, myelinated nerve fibers. He didn't have any symptoms. But when you did an MRI, when you have a disappearance of myelinated nerve fibers, that can be the first sign of a demyelinating disease. This patient didn't have any symptoms or any signs or anything clinically, but just came for routine checkup. We found that the myelinated nerve fiber disappeared. We found this thing, and we did an MRI for this patient. The patient had a demyelinating disease, like multiple sclerosis for this patient. Again, very important for you to understand, especially for ophthalmologists, When you have disappearance of myelinated nerve fibers on one side, and the patient is absolutely asymptomatic, also they can have multiple sclerosis. Leukemia. Okay, the leukemia can cause leukemic retinopathy because they can have problems in the bleeding, in the bleeding time and the clotting time, and this is again you can see multiple hemorrhages. This patient unfortunately died of leukemia, and the rot spots, the flame and blot hemorrhages, the cotton hole wood spots. Again, CFAN neovascularization, very typical of this, can occur in sickle cell anemia or sickle cell retinopathy. Again, the eye is the window to the soul. Future is going to be artificial intelligence enabled retinal vasculometry. This again, Google is doing a lot of work on that. Based on the caliber of your retinal vessels, we can find out what is the risk of your cardiovascular problems you can occur in the future. What is the risk of heart attacks and myocardial infarction? This goes for MI and stroke, and even for the CVA. All this can be done with a based on the artificial intelligence, which you are doing a lot of work as well. The eye is the window to the soul and often the first window to the systemic disease. Ocular findings may precede, accompany, or reflect the severity of the underlying systemic illness. Systemic diseases such as diabetes, hypertension, thyroid disorders, autoimmune diseases, infections, neurological disorders, and genetic syndromes produce characteristic ocular manifestations. Early recognition of these signs enables timely diagnosis, multidisciplinary management, prevention of irreversible vision loss, and systemic complications as well. Take home message: recognize the eye, diagnose the body. Every sign is missing or a hemorrhage, corneal ring, or an optic disc change may be the first clue to a life-threatening systemic disease. So please understand, I tell all my postgraduates, residents, and fellows, when the patient comes in, don't look only at the eye, look at the body, look at the way the patient walks into your chamber. It's very important for you to see the patient as a whole because the eye can be only the tip of the iceberg. So this is very, very important for you to understand this. Thank you again, IMA, for the wonderful opportunity, the patient attention. Again, sorry, Nirmal, about the technical glitch we have, some problem in the connection here. Thank you. I'll stop sharing my screen.
Thank you so much, sir. It was a wonderful, in your words, 360-degree coverage of ophthalmology and systemic involvement. Over to the chairpersons.
Thank you, Dr. Mohan. It's really what the ophthalmologists should not miss, you highlighted all the points for ophthalmologists. Thank you, Dr. Mohan. Nirmal, can we go on to the next speaker?
Just one more, small interruption. So, Madhavan here. Hello.
Yes, Madhavan.
Yeah. Few questions that had been put in the chat box for Dr. Mohan. Just only one question. Lag period between diabetic retinopathy and nephropathy. Dr. Mohan Rajan. Hello. Okay. Am I audible?
Yes, Madhavan. Madhavan, you're audible. Mohan, yeah. I don't know if you. Mohan is not available most probably.
I think he has a bad connectivity, sir. He will join soon.
Okay.
Maybe go to the next talk and then take the questions, sir.
That's right.
Madhavan, just
I joined here, but normally when you're able to hear me?
Yeah, yes, sir.
Yes, Mohan.
Yeah, normally after
it's not very clear, Mohan. Voice.
Okay, we can talk later, no problem.
Yeah, yes, sir.
Yes.
You have okay, when you have diabetes,
Dr. Rajan?
Mohan, sir.
We'll go to the next speaker, Mohan.
Yeah.
Diabetes mellitus. There's a possibility of
So,
Mohan, sir, we'll come back to you
sorry.
after this talk. We'll take the questions. So
Now we have Dr. Kavita Lakshmi Madam from Tambaram, very proficient cataract surgeon as well as refractive surgeon, active both in TNOA as well as in IMA, and she'll be talking about the red eye decoded. So as Dr. Ravi Kumar was telling, any foreign body of the eye, redness, what do we do? Whether it's a harmless red eye or it's a sight-threatening red eye, I'm sure Dr. Kavita Lakshmi Madam will throw light into it.
Thank you, sir.
Dr. Kavita Lakshmi Ma'am.
Thank you, sir, for the nice introduction. And I hope my screen is visible.
Yeah.
Yes. Make it full screen, Kavita.
Hope it is visible.
Request the
Yes,
others
ma'am. Yes, ma'am.
to mute
Yes,
yourself.
and my voice is
Visible,
also audible, right, sir?
Yes.
Audible.
Okay, okay. So before I begin, a very good afternoon to one and all present here and to all the delegates who are here, a very good number of delegates for this wonderful initiative. And I thank Dr. The organizing team, AMS conference and Pollachi IMA for this wonderful opportunity, and also Dr. Nirmal Frederick, who is the chairman of academic medical specialties, for making me be part of this wonderful annual conference. And I really appreciate and admire his excellent initiative and exceptional leadership in actually collaborating and strengthening the interdisciplinary approach and bringing about a very wonderful AMS program. And I acknowledge the presence of the state president, Dr. Sridhar, and also the President-elect Dr. Ravi Kumar sir, and our own AOS President, President-elect Dr. Mohan Rajan sir, whose charm and enthusiasm, he always infuses him wherever he goes. And to speak after him is a very big challenge, and it's a very huge task. But anyway, I am challenged, and I feel privileged that I would do justice to it. And I also delighted to acknowledge the presence of our esteemed past president, Dr. Thangavelu sir, the PPLS sister, Dr. Sendal Kumar, and our president-elect Dr. Madhavan sir, who's all present here. And with this, let me start the topic for today, which is red eye decoded, telling the harmless from the sight-threatening. So let me begin with just two tales of two women. One is a 75-year-old lady who actually got admitted in a hospital, a multi-specialty hospital, with complaints of giddiness, vomiting, headache, red eyes, and she was treated as gastroenteritis, hyponatremia, and viral conjunctivitis. 3-4 days later, she presented to our clinic with profound loss of vision. And we looked at her eyes. Her vision was just counting finger close to face. Her cornea was hazy. And we examined her pupil, which was mid-dilated, and her IOP was high as 58 and 62 and right eye and left eye, respectively. So the catch here and the clinical pearl is, please examine her pupil. The pupil is actually the clue to clinch the diagnosis. And it turned out to be an acute angle closure glaucoma, which was treated as acute gastroenteritis. And we had to install IV mannitol and bring her IOP down, and then go ahead with the management. But the golden hour was actually lost. So whenever you see a red eye with 5H, headache, vomiting, halos, hard eye, half-dilated pupil, hazy and steamy cornea, you have to definitely think of acute angle closure, glaucoma, and that should be the first in your differential diagnosis. And similar conditions can also occur after over-the-counter medications like pseudoephedrine, or the ones which is prescribed for migraine, the topiramate, and antidepressants that can also provoke an angle closure glaucoma in patients who have a very shallow anterior chamber. And this is another 75-year-old lady. And sometimes redness or red eyes will not follow the typical textbook description. So when it is not following the typical textbook prescription, we have to think beyond the obvious. And so this is, she presented after 4-5 days of redness and congestion. She was treated with antibiotics and anti-inflammatory elsewhere, but under slit lamp examination, we spotted a worm was wriggling under the conjunctiva. So under the topical anesthesia, we took her to the OR, and under topical anesthesia, we made a nick and just caught the worm with the forceps and removed the worm. And we were curious to know the length of the worm, and so we uncoiled it. It was a live worm, and it was still wriggling, and it was found to be around 75 millimeters. And we were also curious to know what was it, and so we sent for a PCR analysis, and it turned out to be a Dinophilaria repens, which is a nematode. But the purpose of this session is actually, you will not remember every diagnosis like Dinophilaria repens, but you will know which red eyes you must never treat as simple conjunctivitis. So this is football season, and a red card would mean so much to Lionel Messi and his die-hard fans. And it also means beauty, romance, glamour, red eye, stop alert, as well as revolution for communism. And for a chef, it would mean so much of this. But an ophthalmologist, it is just a simple clue and never a diagnosis. So one color, countless meanings, one symptom, many diagnoses. The world celebrates red, but we investigate it with just one goal: save sight and save life. So the 5 questions we need to decode is a patient reduced? Is there a significant pain or severe intense photophobia? Is it unilateral or bilateral? Is there any contact lens use? Is there any history of trauma or a chemical injury or any recent surgery? And is there any systemic red flags such as a fever or orbital symptoms? If the patient says yes, then please assume that it is sight-threatening until it is proven otherwise. So also follow the 5 patterns of congestion. Just have a torchlight or a slit lamp examination if possible. Then look for a circumciliary congestion. If it is this circumciliary congestion, a congestion which is illustrated as around the cornea, you should definitely think about an acute iridocyclitis and look at the pupil. It will be usually pinpoint, and if a mydriatic or a cycloplegic was already used to treat it, then it may assume a festooned or a different irregular pattern as well. And if it is sectoral or focal, you can think of scleritis, which Dr. Mohan Rajan sir had actually dealt with in detail. And if it is diffuse and bulbar congestion is there, then most probably there is a possibility of a conjunctivitis. And if you see some jelly-like Tranta spots which are present around the conjunctiva, it could mean a vernal catarrhal conjunctivitis or an allergic congestion also. And this follows a mixed pattern, or it doesn't follow any pattern, but usually our OP patient comes very alarmed, very panicked, and really worried, but usually it'll be painless, and the patient's redness would have been noticed by only others. So this is a simple subconjunctival hemorrhage. It would have been brought out by some triggers are a bout of cough or a sneeze, or they would have rubbed violently, or they would have strained at stool, or sometimes an elderly patient who had been on an anticoagulants for a long time, and a gentle rub also could cause something. And it would resolve on its own or with vitamin C supplement on a placebo's lubricants as well. So a startling bright red patch anywhere in the conjunctiva, it could mean a subconjunctival hemorrhage as well. Please probe into the history. So the 5 steps that we need to follow to decode the red eye is: always listen first and look later. History plays a very significant role. Always check the visual acuity, look at the pattern of redness, inspect the cornea and the anterior chamber, check the pupils, and if possible, IOP digitally also. So I would run through a few interesting cases. So this is a 25-year-old bilateral red eye who presented with itching and watery discharge. The vision was absolutely normal. The cornea was clear. There was no significant history or red flags. The preauricular lymph node was enlarged. So probably harmless. It is a case of viral conjunctivitis and treated with antibiotics and lubricants, though it is to avoid the secondary bacterial infection. And not every red eye is conjunctivitis. It can be a dry eye, which Dr. Kalpana would be dealing it in detail, and it could be a blepharitis, and as I mentioned earlier, a subconjunctival hemorrhage and an allergic conjunctivitis with chemosis as well. And even the simple viral conjunctivitis need not always be simple, because these days the virus is so very virulent, and they keep hitting the cornea with such recurrent corneal erosions. And after 3-4 weeks, once the infection settles, it recurs in the form of subepithelial punctate infiltrates, which is in the visual area, and it threatens the vision as well. So please avoid steroids in the acute phase, but reserve it for them in this punctate epithelial keratopathy, subepithelial keratopathy, in order to restore the vision. So, but be aware of sight-threatening and even life-threatening conditions. Some of the sight-threatening ones are the microbial keratitis, the hepatic viral keratitis, the anterior uveitis, wherein you will find severe pain, photophobia, and a very small pupil, scleritis, and acute angle closure glaucoma, the case which we began with. So this is another case wherein you find that a 24-year-old lady, she was a contact lens user. She presented with such corneal infiltrates, and whenever you see this, always ask them to stop contact lens use, and then immediately refer to an ophthalmologist, because this could be so rapid and sight-threatening. It is such a progressive condition, so you have to prescribe hourly broad-spectrum topical antibiotics and immediately refer. And in case of an injury with some vegetable matter, it could even mean a fungal etiology. And then a child with fever, painful swollen eyelids, and you have proptosis, extraocular movements are really very painful and restricted, and the reduced vision is there. Is it an eye problem or a systemic emergency? Always treat it as a systemic emergency. Start prompt systemic antibiotics. It could be a preseptal or an orbital cellulitis. A close review within 24 to 48 hours with a very low threshold to escalate and to image if any orbital red flag signs appear. Be aware of the danger zone of the face, and also look out for the source of infection. It could be a hordeolum internum, or it could even mean a sac infection as a acute dacrocystitis also. But a few can be life-threatening. So whenever you see a bilateral proptosis, as well as chemosty and high-grade fever and significant reduction in vision, means you've crossed the septum, and the extraocular movements are all totally restricted. It needs urgent imaging and escalation. It could be cavernous sinus thrombosis also. So the context of redness is often more useful than the actual redness itself. So whenever you receive a call, a patient in the ICU, and is having some kind of a redness, so he is actually comatose and is on ventilator, then there is a high chance that the patient may be having exposure keratopathy, because his eyes is only half closed. So to prevent such a condition and prevent it from going into a corneal ulcer, please tape the eyelids and also drown the cornea with lubricants. And if an ulcer happens, please treat appropriately. So in ophthalmology, the story often sees the diagnosis before a torch or a slit lamp does. So history and the patient story clinches the diagnosis in 60 to 70% of the cases. So let us see some of the cases which wherein the history plays such an important role. A 45-year-old gentleman had been to the salon for a haircut, which he developed, after which he developed redness and irritation. And he presented with severe irritation and congestion of the eye, but we couldn't find anything. Then we stained with a fluorescent dye, and here you can see on the right side, this fluorescent, has taken up, and you have the fine fluorescent taking it up. So these fine erosions indicate that a foreign body is definitely present, and on searching for a foreign body, we really spotted one. It was a cut end of the hair, which was seen jutting, and it was, we tried to pick it with a fine tipped jewel forceps, and we managed to remove the foreign body, and you can see the cut end of the hair, which caused so much of irritation and corneal erosions and abrasions. So the fluorescent dye is your detective. So whenever you see such kind of fine abrasions on the cornea, the patient presenting with irritation, please use a fluorescent strip, stain it, and then examine and invert the lid, because most often the common site where a foreign body is lodged is upper tarsal, subtarsal areas. And here is another upper tarsal foreign body wherein a thorn got stuck in this. Very often, a lot of insect wings also can actually be a foreign body. This is another interesting case where you will find that it was treated as a corneal ulcer. It was taking up stain. They were treating it with antibiotics for a long time. Later on, he presented to us, and then when we saw, we could find a slit beam, and there was a little bit of elevation. It turned out to be a transparent foreign body, which was just stuck on the cornea like a cellophane tape. And we removed it, and the patient was happy. And this was a 5-year-old boy who presented with severe watering. He refused to open his eyes, and the patient presented after almost 3-4 days of watering and lid swelling, and made him to open his eyes and examine him. And here is a metallic foreign body which was stuck on the cornea, and we removed it. So this is this 18-year-old mechanical engineering student. After a lab workshop from the mechanical engineering department, either by ignorance or by reluctantly, he did not wear the anti-UV goggles, which he is supposed to wear, and he landed up with such welding arc keratitis with such fine punctate erosion, severe photophobia, was unable to open his eyes, and then we had to treat him for 2-3 weeks with lubricants and mild steroids and antibiotics. And this is Insta era for Insta results, and a reel to fix hair fall could nearly cost the patient their sight. So seeing an Insta reel, this girl had been applying custard apple seed powder to wash her hair. And then we know that the custard apple seed powder contains acetogenins, which is so very toxic to the cornea. It has caused so much of epithelial defect, more than the toxic effect of the seed powder. The irritation and the subsequent rubbing had caused so much of corneal erosions and epithelial defect. So it took nearly 2 weeks, 3 weeks for the epithelium to get back to normal. And when anything gets into the eye, please do not rub, please flush well and seek care immediately. So September comes, Vinaya Chaturthi comes, and this calotropis juice keratitis patients also just crowd our OP. So whenever you see a patient with such diminished vision and corneal edema or a steamy cornea, always think of this. If they have handled this Erukampu mala, then this type of a keratitis would happen. So you need to treat them with mild steroids and lubricants. It usually clears off. Herpes zoster ophthalmicus, which Dr. Mohan Rajan sir had actually presented in his slide. So whenever the tip of the nose is involved, always assume that the eye is involved, and please refer to an ophthalmologist for further management, because it could be a keratitis or a uveitis as well. So any history of trauma, look for high femur, and it could also mean traumatic recession, glaucoma, and so many things. So I would like to stress on the importance of torchlight examination rather than a direct torchlight examination. Just examine with an oblique illumination, because it will lit up the cornea, and it will light up and illuminate the anterior chamber, and you can inspect it so very well, and you can never miss the glow. So red eye can be compared to an iceberg. The tip is a common conditions like conjunctivitis, subconjunctival hemorrhage, and a dry eye. So you can actually manage it on your own, but beware of the waterline, and they can be sight-threatening, like the ones episcleritis and corneal abrasions and corneal ulcers, which you have to have a very close follow-up, or you have to refer to an ophthalmologist for that to be managed effectively. And but never miss the deep abyss, because the hidden acute angle closure glaucoma and so many other things can be really sight-threatening, and missing them would cause their vision and sometimes their life. So any of these symptoms or signs require same-day ophthalmology assessment. If there is severe vision loss or severe pain, marked photophobia, contact lens wearer, corneal involvement with opacity or an ulcer or an epithelial defect, distorted or irregular pupil, and if you suspect a raised intraocular pressure, if there is a history of trauma or a chemical injury, fever or systemic toxicity and orbital signs, and whenever you're in doubt, do not prescribe steroids and do not label it as conjunctivitis and do not delay referral. So my take home would be red eyes. So examine the pupil, use a fluorescent dye and light up the cornea and get the close. So the red eye is decoded for your eyes only. So as you leave today, carry a little James Bond with you, be Dr. Bond and spot the clues and clinch the diagnosis. Thank you. Thank you so much for the opportunity.
Thank you, madam, for wonderfully decoding the red eye. And as Dr. Kavitalakshmi madam said, there is harmless red eye, subconjunctival hemorrhage, conjunctivitis, dry eye. On the other hand, emergency red flags in the form of visual loss, severe pain, pupil changes, halos, and of course, trauma and chemical injury. And one take-home message: not to use steroids indiscriminately. Thank you, madam. Thank you for your wonderful presentation.
Thank you, sir. Thank you.
Madhavan, you can call the next part. Madhavan?
Yeah.
Very nice talk, Kavita.
Thank you, sir.
Very nice.
Excellent, in-depth. What we should know, no? All ophthalmologists also should learn all this. And the
Yes,
others,
sir.
there are a lot of take-home messages. Definitely, I think when you see a red eye, it is not to be taken lightly. That's the message. Madhavan?
Yeah. Now we have dry eye in the screen era beyond lubricating drops. And we have Dr. Kalpana Suresh madam, former president of IMA Porur, and a very active in TNOA. Looking forward to her talk in this AMS conference. Over to you, madam.
Thank you, sir. Is my screen visible and am I audible?
Visible, audible.
Audible.
Please go on. Please go on, doctor.
Thank you, sir, for this wonderful opportunity. Respected organizers, chairpersons, and all the delegates who are taking time to attend this webinar. A very good evening to all. At the outset, I extend my sincere thanks to the entire IMA team and Dr. Nirmal, the chairman, IMA AMS wing, and the entire team and the panelists for this wonderful opportunity. So after the two speakers, I promise to keep you awake with my speech. So I have no financial interest to disclose. 1 minute. My slides are moving.
Yes, madam. Yes, it's moving.
Dr. Kalpana, can you make the screen full screen?
Oh, 1 minute.
Yeah, now it's better.
Yes. Full
Yeah.
screen.
So there are a lot of dry eye signals you have to know. It's not that the patient will. Why is it not moving? Ah, yeah. So the patient can present with eye irritation, foreign body sensation, fluctuating vision. That you have to know. because the patient might say the vision is a little blurred, and after each blink, the patient's vision improves. So that is a fluctuating vision is very, very important. And to fix this dryness problem, the patient can have a reflex tearing. That is, in dryness, you can have reflex tearing also. And in extreme cases, the cornea can go in for damage and you can have severe pain. It can become painful in later stages. So this is a huge classification proposed by Dry Eye Workshop 2. I'm not going into details of this. Basically, you have two types. That is evaporative dry eye and tear deficient dry eye. And there's a mixed variety in between these two. So if you ask me what is the number one cause of dry eye, I'll usually say it's meibomian gland dysfunction. Reduced tear production is also contributes, but to a lesser extent. So commonly due to aging, all these changes happen in the gland and they produce less oil, and also the atrophy happens. That's beautifully explained by the systemic manifestations in his presentation. Dr. Mohan Raj said all the connective tissue disorders can be associated with the dry eyes. It's very important to see the patient as a wholesome. And if the patient has a dry mouth also, you place a diagnosis of patients having Sjogren's syndrome, where it's an autoimmune condition affecting both the lacrimal and the salivary glands. So it's associated with both dry eye and dry mouth. So which we measure the amount of tear production by Schirmer's. Don't forget to ask the systemic medication intake by the patient. Most of the medications will cause associated dryness. So that might be the culprit in many cases. So majority of the patient belong to this evaporative dry eye. As I mentioned, it's around 80%. The rest will be aqueous deficient and a mixed type. Basically, this is a small model of the tear film. Tear film is not a single layer. It has three important components in it. Aqueous layer is the most important, that is shown in blue here. That is secreted by main and axillary lacrimal glands. That has lots of proteins, electrolytes, and growth factors, which is necessary to maintain the ocular surface health. And how is this attached to the hydrophobic eye surface? Is by means of this mucus layer, that is mucin secreted by goblet cells in the conjunctiva. So this sticks the aqueous layer onto the ocular surface. And what prevents the aqueous layer from evaporating is by means of these meibomian glands. This oil secreted by these meibomian glands situated in the lids. These are meibomian glands. This is a lacrimal gland. This is a model of how the tear film interacts on the ocular surface. So if you see any patient's eyelids in a magnified manner, you can see some small tiny dots. See how it's looking like some small pustule or a pimple. So this is how an inflamed meibomian gland will look like. And here if you press, you will get some toothpaste-like excrescences from the orifices. This is absolutely not normal. This is almost the end stage of meibomian gland dysfunction. So how do you assess these glands? These glands are situated in both in the upper and lower eyelid, 20 to 30 in the upper eyelid, around 20 in the lower eyelid, vertically. So there's a special instrument now. The dry eye diagnosis and therapy have improved a lot. You have special infrared cameras. You can see the meibomian glands in both the upper and lower eyelids. So when due to some disease, meibomian gland dysfunction, these number of glands can reduce, then they can drop off and finally atrophy. In this stage, nothing much can be done. So our aim is to prevent the progression of the disease from this stage to this stage. So that's very, very important. So here is a lower lid of a patient. You can see these tiny, clear, beautiful oil droplet like it's a super healthy eyelid with a good ocular surface. And here you can see the oil capping and the fluid is little turbid and yellow, opalescent. This is the next stage. And here you can see something solid like a wax coming out of the eyelid. This is a very severe stage of meibomian gland dysfunctions. So you have a lot of diagnostics. The Schirmer's, that is for diagnosing the aqueous layer. And to find out how about the health of the ocular surface, you have this fluorescent staining or rose bengal or lissamine green staining of the ocular surface. Here it's a normal ocular surface, doesn't take up any stain, both the conjunctiva and the cornea. Here you can see stipple green stain of the cornea, showing that this area is devoid of the proper tear film. That is, the tear film is very unstable, causing a lot of corneal erosion. This stage, the patient can have severe redness and pain. It's a painful eye. Coming to diagnostics, shim, as I has already said, and you have these keratograph machines where you can, without touching the patient, that is shimmers, you keep a strip in the lower fornix and measure the amount of wetting at the end of 5 minutes. But in this non-invasive techniques, you can see without touching the patient, the breaking of these Myers and also the tear film meniscus. That also you can measure with these keratographs. So tear film meniscus, that you can see in the slit lamp also. So while examining the patient before dilating or putting any eye drops, it's better to check the tear film height in the lower lid, which has to be around 1 millimeter for a healthy ocular surface. So this is just to look for the tear meniscus height. And you have plenty of tear film breakup patterns. I'm not going into the details. By looking at, you instill fluorescent and look at the pattern of tear film breakup. By looking at the breakup of the design or the pattern of breaking, you can find out whether it's aqueous or mucus or evaporative or decreased wettability type. That's a little tricky thing. So as again, what causes meibomian gland dysfunction is the aging. As age advances, the gland function, the secretory capacity, acini all drop out. The number of glands also come down. And also there's hormonal factors which are very important. There are hormonal receptors in the meibomian gland. You have androgen receptors and estrogen. They are responsible for good quality of lipids. So if they are low, especially in postmenopausal age, you get severe dryness, that is due to estrogen deficiency. Progesterone also plays an important role. Reduced progesterone will cause epithelialization, keratinization. So that can be blocked due to keratinization. That also is there. So all these aging changes can lead to MGD. MGD is meibomian gland dysfunction. And environmental factors play a very important role. So you need an optimal humidity for the meibomian glands to function. Whether extreme humidity low or high, the meibomian gland dysfunction happens. And we literally live in air conditions, whether at home or at car while driving or in the hospital or work at home or it's in gym, everywhere the AC is there. So that in air condition, the humidity will be very low. That will be the main cause along with other combined causes in digital screen time use. And this is the most overlooked entity, that is blepharitis. It is inflammation of the eyelid margin. So whenever there is plenty of scales in the lid margin, that is, it can be due to bacterial blepharitis, that is staphylococcal blepharitis. Why is it important? Why is it related to meibomian gland? These staphylococci, they release a lipolytic enzyme and which can degrade the oil. And it can release inflammatory cytokines. That leads to inflammation, both inflammation and there is no good quality of lipid layer covering the tear film. Hence, evaporation is rampant. So this is very important. This can be easily understood in the initial stages. So this should not be overlooked. It's very, very common in youngsters. So blepharitis. And if you see such scales in a cylindrical form, these are cylindrical scales, you have to suspect
dogs.
mites. Can the participants make?
Yeah, please go ahead.
Kalpana, unmute.
IMA team, please unmute Dr. Kalpana. She is the speaker.
Madam, please unmute yourself, madam.
Unmuted, madam.
Dr. Kalpana, can you please unmute yourself? We are not able to hear you.
Yeah, even if an unmute, somebody mutes me.
Okay. No, I'll
You
tell
can
you.
hear now?
It's audible, Doctor.
Yeah, we
Yes,
can
Audible.
hear.
you are audible.
We can
Yes.
hear.
Please continue.
So it unmuted from now onwards or for the previous slides also?
You can proceed. I think from the previous slide. From blepharitis.
Okay.
Yeah.
So blepharitis is a condition very, very common, but it's much overlooked these days. It's very common in youngsters. So what happens is blepharitis usually caused by staphylococcus, and these staphylococcus feed on these act on these oil secreted from the meibomian glands orifices on the lid margin, and they release inflammatory cytokines. So this inflammation along with absence of oil leads to evaporation, and this sets up a aggravates the meibomian gland dysfunction. So this definitely, unless you treat this, MGD will not settle. So next, most one of the commonest mite affecting the lid margin is the Demodex foliar, Demodex blepharitis. So if you see such cylindrical collarettes along the lash line, lid margin, you have to suspect Demodex. These are little mites. There are two types, Demodex follicularum and Demodex brevis. They live in the eyelash follicles and the meibomian gland. But if they are normal commensals. But if they are excess in number, what they do is they eat up the oil, and hence the oil becomes deficient, sets up inflammation the same way, and the tears evaporate. So unless you treat this, your dry eye is not going to settle. Again, rosacea, it's also common, but it's very difficult to diagnose in dark complexioned individuals. Rosacea is also more associated with Demodex and hence MGD. And all these anti-aging creams, so we have to be very, very careful because they contain retinol, and that can cause inflammation of the meibomian glands and lead to dry eye. So most of these, if they use in and around the eyelids, you have to be very careful. And also the eye drops which you use for treating glaucoma, which has to be lifelong. Not only glaucoma, but all the other tear substitutes, if you use inadvertently, it can cause dry eye because of the preservative called benzalkonium chloride. It's very toxic to the surface. And for a few days or few weeks, nothing will happen. But over a period of months or years, it can lead on to ocular surface damage. So this history also you have to note down. Contact lens again, apart from causing the red dye, it can cause the mechanical damage, or it can induce allergy and inflammation, and it can lead to dryness in the long run. And makeup, ladies, please excuse me, if you use makeup along these lash lines where the meibomian gland orifices open, you are going to block the entire orifices, and hence the oil will not flow freely, and these chemicals also can be toxic. So please leave out these lash line, and then you can apply anywhere outside. So this also you have to suggest when you examine the slit lamp. You look at the kajal or any makeup stuff close to the meibomian gland orifices. So digital screen time is very, very rampant now. Mobile everywhere, at home or office, laptop, desktop, TVs. So this is why is this causing dryness? There are multiple factors. Number one, the blink is reduced. Blink rate and the quality of blink also is very, very poor. So normally when you blink end to end, the lids have to touch each other, and then only the meibomian gland will secrete lipid, and that covers the surface and prevents evaporation. During the intense screen time, they're playing or watching TV or whatever it is, the blink rate, number of blink also is reduced. Normally it is from 10 to 15 per minute. It's reduced drastically, maybe less than half. And the quality of blink, it's only half-hearted blink. If the eyes don't meet, the oil doesn't secrete. So eyelids don't meet, the oil doesn't secrete. So it has to be a complete blink. Partial blink is of no use. So that is the main factor, along with low humidity and pre-existing disease can aggravate the dryness in this digital era. So what steps you can take to prevent or reduce the occurrence of dryness? Take a screen breaks. That is the famous 20-20-20 rule. Every 20 minutes, take a 20-second break and look at a 20 feet, look at an object situated 20 feet away. It's practically. And whenever you remember, do a complete eyelid to lid blink. Keep it closed for at least 5 seconds or so, minimum. Or humidifier, if the humidity is quite low, this can drastically improve the condition. And eyelid cleaning, periodic eyelid cleaning is a must. Because most of us just wash the face and wipe it with a towel. And if there is any itching or dandruff-like material, please use earbuds. Earbuds, you can dip it in diluted shampoo, baby shampoo, and then clean the lids to remove the scales. It's very, very important. And if your patients are using makeup, definitely it has to be removed before sleep. We should not sleep with all those makeup stuff on the eye on. And the scalp dandruff, better to use the anti-dandruff ketoconazole or selenium sulfide, because that is mostly associated with the blepharitis, scalp eyelid blepharitis. So unless you clear the scalp dandruff, this is not going to clear. And also, don't keep the fan or AC directly blowing onto the face. That will in turn worsen the existing dry. It can evaporate the existing tears also. So in meibomian gland dysfunction, this you can do at home. Keep warm compresses. This will melt all the tough oil or waxy oil in the lids. Next step will be massage the eyelid from above downwards to express all the oily stuff, and below upwards from the lower lid. And once all the oil gets collected, clean it with a butt dipped in diluted shampoo. These are 3 steps followed meticulously to if there is early MGD. And medications, we have plenty of lubricants, and if the surface is very much inflamed, we use topical steroids or topical cyclosporin also in some cases, tacrolimus also, and oral doxycycline as an anti-inflammatory therapy. This is not given in full dose, we give only half dose to reduce the inflammation, and omega-3 too. So if you are prescribing steroids, beware of the cataract and glaucoma that can run in patients who are who shows steroid response. That is, they are called steroid responders. So we have to be very careful in prescribing steroids to these patients. So latest is thermal pulsation and IPL. I'll end with that. Thermal pulsation is, say what the steps I showed, warm compresses, lid massage and expression. This machine does this. So it gives heat, it melts the sebum and it compresses and removes all the lipid which is stagnated in the meibomian glands. Physically, it can express all these glands out. This is very, very essential, very, very useful. And also the IPL therapy, this gives intense light pulse. This modifies the vascularity, reduces the inflammation of the meibomian gland so that they become active or energized once again. But all these things will work only if the patient has adequate amount of meibomian glands. If they are totally atrophied, nothing is going to work. So thank you for this wonderful opportunity, and thanks for the patient listening.
Thank you, madam. That was an excellent presentation. Just have a question. Most of the things, diagnosis and other things are based on a slit lamp examination.
Yeah.
For general practitioners, and other specialists, what all gadgets do you suggest? Like Shomos, and what all things do you suggest which will be useful for them to diagnose it?
Diagnosis, as I already said, history is very, very important. Just find out the cause. If you have a detailed history, definitely you'll come to. See, there'll be multiple factors responsible. Not only the screen time, we mostly blame most of them with the screen time. But you have to find out the simple thing, the blink rate you can assess. As and when the patient is sitting in your office, you can make somebody observe the blink rate, or others to observe the blink rate. Blink has to be complete. And if there is any dandruff, better to treat them. I don't think we require
Do you suggest something like
to purchase some equipments for.
No, madam. Just like a binocular loop or magnifier, torch, Shomos, these basic things. Do you suggest?
Shimmers you can, okay. Shimmers is very simple that you can, people can use. The wetting less than 5 millimeters. See, there'll be a notch in the shimmer and there'll be a gradations. So wetting less than 5 millimeter, definitely it's a severe dryer. That you can use.
And this binocular loop, madam?
Loop is, I don't think that's.
So you had showed demo
See, you have a very good mobile phone cameras now. You can take a good picture, a HD quality picture, zoom and see if there are any blepharitis or anything. So
that's a nice
advice I can give. With a bright illumination and a good HD camera, you can see actually. So blepharitis, that's the only thing that they can treat. And meibomian glands also, if you can willing to invert the lid, you can see the vertical glands, the number and quality.
Thank you, madam. Shall we go to the next session? Myopia search.
Kalpana?
Sir? Yes, sir.
You are able to hear me?
Yes, sir. Yes, sir. Is it audible, sir?
Audible, Dr. Sandeep.
Yes, sir. Yes, sir. So, shall we go to the next?
You just take a blunt poser. Sorry.
Sir is online. I think connection is interrupted. I believe.
Connectivity is not so good, Sandil. We'll move on to the next speaker.
Yes, sir. Yes, sir. So, Dr. Shruti Nishant, the myopia search. Can we slow it down? Please, madam. Over to you, madam.
Yes, sir. Good evening, everyone. Can you see my slides, sir?
Yes, madam.
Okay. So a very good evening to everyone. I'm indeed very honored to be part of this wonderful group of doctors, and it's a first time for me to be a part of an IMA Amscon conference. It's just tremendous looking at the numbers of people who have registered and the people who are also continuing their interest in the talks, and the numbers are not decreasing. So it's really nice, sir. Thank you so much, Dr. Nirmal Frederick, for the wonderful opportunity, and for the entire team of Amscon. So myopia is something that we've all grown up learning in our textbooks and all of that. But why is it coming back into play in the recent times? And this is something I'll be discussing today. So myopia is primarily a refractive error where the rays of light that are entering the eye, and this is just a revision for most of you, as you would know, they enter the eye parallel to the optic axis but are brought to a focus in front of the retina when the accommodation is relaxed. And what a pair of concave lens can do is to bring the focus slightly behind and put it on the retina. So this is because the eyeball is slightly enlarged and it's gone behind. So you need an additional lens, concave lens, to pull the focus back onto the retina. So this is a definition. When we look at how the actual accepted classifications are, myopia is considered as a condition where the spherical equivalent refractive error is worse than -0.5 diopters, when the ocular accommodation is relaxed, basically after a dilated examination using cyclopentolate or homatropine. Low myopia is where it's between minus 0.5 and minus 6, and high myopia is a condition where it is more than minus 6. Now, this both IMI, that is International Myopia Institute, as well as World Health Organizations have a little different classification of high myopia. The World Health Organization calls minus 5 as high myopia, whereas IMI considers minus 6 as high myopia. That's because IMI would probably is looking at permanent retinal damage as a sign of significant myopia. So that's why they call it minus 6 as high myopia. Now, when we move forward, why are we worried about myopia? It's just a pair of glasses, right? No, the prevalence of myopia, childhood myopia worldwide is increasing. And this is this is a wonderful pictorial graph and study that is done by Holden et al., where they postulated that globally, around 50% of the world's population are going to end up myopic by the year of 2050. And we are actually correctly following the trajectories on the global prevalence level. But if we think it's just a global problem and not an Indian problem, well, again, we are mistaken, because even in India, a similar study was conducted where again we found that 50% of the population will probably become myopic in the coming next 2 decades. So when we look at why we are worried, it's probably because each diopter increase in myopia increases the risk of myopic macular degeneration by 67%, and slowing myopia by about 1 diopter, just slowing it by 1 diopter, can reduce the likelihood of developing these permanent retinal changes by a staggering 40%. So this is the reason why we are concerned, and that's because we don't want our children of the future to be wearing glasses forever. And this is what I was talking about. This is a normal fundus on the left, whereas you can see the grades of the changes that the fundus undergoes with age. And this is severe myopia, maybe around minus 16 to 20. You can see the kind of permanent retinal changes. It's not just the fundal appearance. If you go in and look at the OCT or the optical coherence tomography, you actually notice these posterior staphylomatous changes where the entire eyeball kind of goes behind, it herniates behind, called as posterior staphyloma. And this is what the curve that you see here. And if you look at it, it's not just the posterior staphyloma. There are actual tractional changes happening in the vitreous. This is something called myopic tractional maculopathy, which happens in high myopia. And this is where the vitreous starts condensing and pulling the retina forward. And this is such a sensitive area called the macula. And this is being pulled forward because of the tractional elements. And not just that, we have something called dome-shaped maculopathies, which are seen in high myopia. Again, this is like especially centered around the area of the fovea and the parafoveal region. And you can see these horizontal domes or the vertical domes, both of which cause permanent visual damages. So this is the reason why we want to curb myopia progression. But when we look at myopia as an umbrella term, it's not just one entity, there are 3 entities. It's syndromic, it's high pathological, and the third is the regular myopia that we very commonly see, which is the school-going myopia. Now, when we look at syndromic myopia in the clinics, when you look at certain syndromic features on the child, especially children with ocular cutaneous albinism, retinitis pigmentosa, children with Weil-Marchesani syndrome, commonly seen achromatopsia, all of these children, we need to kind of have a suspicion about myopia in these patients and then refer them. So you could ask for visual disturbances or difficulty in night vision. These two are symptoms you could elicit. Now, when we look at the second and the third entity, high pathological myopia is a little different from school-age myopia. How is it different? This is strongly genetic. It is a rapid extreme elongation of the globe, which happens at a very young age, like less than 5 years of age, and it's associated with very high refractive error. It usually doesn't progress, which is why we don't need to treat these kind of myopic children, and they have permanent degenerative changes in the eye, and it is a relatively rare condition. Whereas when you compare that with school-age myopia, which is the common form, it usually progresses slowly. It happens over a period of time, especially in older children more than 5 years old. It's low to moderate refractive error and stabilizes by the age of 20. The retina, because there's a slow progression, it looks relatively normal with not much of changes except in high myopia. And this is the common form of myopia that we really need to address. Now, how do we suspect myopia in a child? It's the inability to see the board or far objects, blurry vision, any frequent blinking or rubbing of eyes, squinting of eyes, frequent headaches, eye strain, child is sitting close to TV, sometimes offbeat complaints like disinterest in academics. Child is on the autistic spectrum, or child is not looking and having interest, but you'll be surprised to see many of them have actual myopia, which is uncorrected. And of course, behavior issues, anger when you ask them to read something, they throw tantrums, and all of that is probably because they're not able to voice their disdain over not being able to see properly. And of course, if there is a strong parental history or a sibling history, that's another area where we need to refer these children for a myopia checkup to the ophthalmologist. Now, what are the things that influence this disease? Myopia, obviously, we know is a complex disorder similar to diabetic retinopathy. So you have both genetics and environment. What does genetics do? Genetics predicts the age of onset. So younger age of onset is more likely in children whose parents are myopic. The rate of progression is faster in children whose parents are myopic. And the ultimate refractive error which they reach is always higher in children who have parental myopia. When we look at environment, I'll be talking about all of these factors. But remember that genetics is only a small part of the disease. It's the environment that takes the major role. For example, if the genetics is the bullet and the gun is loaded with the bullet, it's the environmental factors which trigger the bullet. And it's important that if we have a good lifestyle for the child right from the beginning, we need not actually release the bullet and the genetics stays safe inside. So remember that genetics is not necessarily mean that it will manifest in myopia in the child. So how do genes play a role? If a child has one myopic parents, the odds risk is 1.8, whereas two myopic parents, it's 2.4. Now, here are some of the suggestions that I usually recommend for my parents when they ask me what are the things I can do to prevent myopia. It's important to give them a good amount of sunlight exposure, especially in the 4 o'clock to 6 o'clock evening time, preferably with some movement or sports. Make sure that during their lunchtime in school or whenever they have a break, that they move outdoors. When their houses are there, when they're in the houses, they should be open, well ventilated, study table next to a window, and where they can take breaks and look far, and make sure that they do not have night lamps, because night lamps are associated with higher myopia risk. Now, when we look at sunlight per se, we are so this is what Dr. Nirmal sir was talking about, that we have developed a wearable sunlight monitor where we track and monitor sunlight in children, and this is an invention that I had done. And we have these beautiful graphs that give us 24-hour sunlight graphs, sunlight exposure for the child. And be surprised to see that children more often than not prefer indoor artificial light to an indoor natural illumination versus even outdoor shade. Forget about bright sunlight. So our children are around this area and not even going near that area. So we need to change this. When we look at near work, these are the suggestions I give. We need to move to bigger screens, higher resolution screens. Obviously, you have all these fancy coatings which prevent glare. You may make sure that the room has ambient light when they watch a screen. Make sure the distance between the screen and the eyes are much bigger. So extend an arm and it should be at least that arm distance. Child should have frequent blinking, as Dr. Kalpana was beautifully pointing out, that blinking completes the tear cycle. A good posture is extremely important because the angle at which we view also has been associated with myopia progression. And of course, to break all of this, frequent outdoor breaks. Now, what does the American Academy of Pediatrics recommend? It recommends no screen time for children under 2 years of age, 1 hour per day for children between 2 to 12, preferably on bigger screens, and 2 hours per day for teens and adults. Now, this is something that I tend to recommend to all our patients, and this will be helpful for you as well. Now, another new thing that has come up is sleep as a risk factor, and children who sleep more than 9 hours a day have been found to have associated much lesser myopia compared to children who sleep 7 hours or 8 hours. And also children who sleep later, maybe beyond 9:30 or 10, also have been associated to have higher myopia risk. So beware of sleep time also. Now, when you have a child coming in for myopia, these are the things that I normally look at. This is the history that I see, the age, the parental history, the sibling history. Allergy is a very important inflammatory risk factor. So ask for allergy history, ask for family history of keratoconus or retinal detachments, because retinal detachments usually run in families, especially with high myopia. And when we look at the dynamic profile, which is the modifiable risk factors, I almost always take a note of the outdoor time, near work, screen time, sleep time, and also how they are compliant to previous interventions. Now, after you profile the patient, these are the tests that I normally do. We do a refractive status, a cycloplegic refraction, and a dynamic retinoscopy. We do axial length measurements. We do the eye axial length measurements, keratometry and corneal topography. And if you wish to do a much more detailed evaluation, you could do relative peripheral refraction, cover test, dry eye, and ocular surface evaluation as well. Now, with this basic information in our hand, we can start treating myopia progression. But do we need to treat everyone? No. We only need to treat myopic children who progress. How much do they progress? More than 0.5 diopters on cycloplegic refraction in the preceding year, associated with axial length change. I understand that not many practitioners will have an A scan. So in the absence of an A scan, we can take a refractive error. But if you do have an A scan for a cataract clinic, then please do an A scan, whether immersion or optical, doesn't matter. This is the progression rate for axial length that we usually recommend. Now, if these two criteria are fulfilled, then you can go on to progress myopia control strategies. Now, what are the commonest strategies used is low dose atropine. This is a new drug that has recently come about in the last 5 years in our country. It's 0.01%, which is 1/100th the dilution of a regular atropine bottle. And it is recommended as a daily dose, that is every night, 1 drop for a period of 2 years. So when we talk to the patient itself, we tell them that this is for 2 years. Every night you will have to apply it. Now, how does it work? It works through the mechanism of dopamine. It improves the dopamine levels in the retina. And not just that, it also increases the choroidal thickness, increasing the blood flow and oxygenation to the retina. So these are the ways in which it works. Now, when we look at how it works globally, there are several studies, the ATOM studies, but more importantly, there are Indian studies that tell us there is a 54% reduction in myopia progression at 1 year, which is really staggering good news for us. And also there's another study again from similar group where I'm at the co-author, where we have also found that 64% of control in progression has been observed in the first year. So this is quite significant control that we see in low-dose atropine. Now, the immediate question that people ask is it a safe drug? Well, yes, this is an ATLAS study which studied these children who were on atropine. After a period of 20 years, they found that this drug has no adverse events. However, they also found surprisingly that it is very similar to placebo group if you treat them with 2 years of atropine. Well, that's because the study had a lot of flaws, but it's important to take note that there were no adverse events at all. So now they have the new atropine, which is the 0.05% for children who don't respond to 0.01%. And again, there are several studies, Indian studies even, which look at the efficacy of this particular percentage. Now, where we should not give atropine is as important as where we should give. We should not give it in astigmatism, retinopathy of prematurity, myopia which is not axial, like positional or lenticular or curvatural myopia. And of course, when in high pathological myopia which do not progress, please do not give atropine. Now, what are special lenses? This is the other new thing that have come up. This works on the principle of peripheral hyperopic defocus. Basically, the eye is curved more posteriorly in myopes. So these lenses bring the rays forward and create a myopic defocus, reducing the blur on the peripheral retina, thereby controlling myopia. So we have something called the DIMS lenses. These lenses have these embedded plus lenses inside which look okay. The patient feels very comfortable wearing them and the myopia progression happens. This is called the HALT lens, again invisible plus lenses but in a ring shape. This is the Zeiss myocare, which are they are refractive elements which are continuous ring segments which are around the central area. How do we fit these lenses? It's important to give them round frames. It should cover the orbital margin fully. Make sure the accurate IPD is taken and make sure the child has close to face and not much farther from their eyes. Now, newer things that have come is the orthokeratology. These are nightwear contact lenses which I have started prescribing. They do beautifully well. You just have to put them on at night and remove them in the morning. The child does not have to wear glasses or contact lens throughout the day and they have clear vision. And also it gives a good control, about 50% of myopia progression control. Now, this is the new thing that has come. We can also combine these therapies. When one doesn't work, you can mix a contact lens with atropine or special glasses with an atropine. And all of them shows excellent results because they all work in different methodologies. Now, this is the slide which I would like to recommend as a flowchart for all of you who want to take up myopia. The children more than 4 years with progressive myopia, my first option would be myopia control spectacles. Based on how they respond, you can either choose to continue them for 2 years. If they're poor responders, you combine them with atropine. If they're absolutely non-responders, then you stop the spectacles and you shift to atropine. Now, in certain conditions like high myopes, high astigmatism, strabismus, and unilateral myopes, you can directly start them on atropine instead of the glasses. So now let's look at two or three cases. First is, this is patient A. She's a 4-year-old, history of parental myopia, bookworm, and very less outdoors. And this is the cycloplegic refraction of plus 0.5 with a normal axial length for age. Now, this is what is we called as pre-myope. So they're not yet into myopia, but they're going into myopia. So give them good lifestyle and then see them after 6 months. Now look at the second patient. This is an 8-year-old boy. You can see there's no parental myopia, very less outdoors and increased screen time. But now you see he has a myopia, is minus 0.75, and axial length is also appropriately increased. So here we consider them as a new myope. Do not start any intervention. Start only on glasses and lifestyle advice and observe 6 monthly. Let's look at this patient C. This was a 10-year-old girl, no parental myopia, again lot of screen time, progression of myopia minus 1 diopter in the last 6 months with increase in axial length. This is a patient where we have to treat. This is a progressive myope. We change the glasses, we start dilute atropine or the DIMS lens, whatever works, and lifestyle advice, and observe them 3 monthly to 6 monthly. So that's about it. These are the examples, and this is my last slide. The myopia boom is amplified by COVID. The environmental factors are more impactful than genetics. We need to understand retinal circuitry. Scleral remodeling is the primary pathogenesis, which can be controlled using dilute atropine or DIMS lens or orthokeratology. So remember that we need to move our children from indoors to outdoors. We need to live outdoors and not just visit it. And this is a simple life that our children should lead in the outdoors, this joy and the sunshine on their face. This is the kind of life they should be leading. Thank you so much for your kind attention.
Thank you, madam. That was an excellent presentation. Particularly the last slide was really appealing, madam.
Thank you,
So
sir.
for want of time, we'll take the questions after the presentations. So, sir, any questions in particular, sir? Audience, any questions in particular? There are no questions, sir.
I
just
wanted to give you one small thing. Are you able to hear me?
Yes, sir. Yes, sir. Please.
Yes, Mohan.
No, because we see a lot of patients with the meibomian gland dysfunction. What I would suggest for all the ophthalmologists is simple test. Take a blunt forceps, like an epilation forceps, and press the lid margin. Then you can see a lot of meibomian secretion coming from the meibomian glands. Okay, these are patients you need very aggressive treatment, especially prior to cataract surgery. Optimize the ocular surface and then take them up and treat them very aggressively. So this is more common than what you can imagine. Yeah. Shruti, wonderful talk as usual. Yeah.
Thank you, Emma.
Shruti, can I, Shruti?
Yes, sir.
Audible? Yeah. Most of them are non-ophthalmologists listening to you, know. What would you tell them when you want to see a myope? What did you tell them to do?
So the thing, so when they see a child, the first thing is ask them for ocular complaints, even from 3 years of old. I'm sure pediatricians are seeing kids much earlier than we are. So even at 2 years or 3 years, specifically ask complaints, whatever I have listed, and then refer them to the ophthalmologist. We are seeing myopes starting at much younger age. So that is one. Second is, I would say that whenever there is a family history, the parents are wearing glasses, without a doubt, please ask them to come visit a pediatric ophthalmologist, because more often than not, one of the child at least ends up having myopia. So these are the two things.
Sir, because all the ophthalmologists are here, I would suggest TNOA to take up a project, even small smaller chart, non-illuminated chart to all the pediatricians.
Yes.
And mentioning that the chart has to be viewed at a distance of so meters. Definitely, it will be helpful in catching the myopes at a much earlier age.
Yeah,
absolutely. Very good idea.
That's a good suggestion, Sendil. We'll work with the IAP Tamil Nadu chapter and see how it could be implemented.
Yes, sir.
And thank you.
You could definitely implement, sir. I know that once you make a decision, you could definitely implement it. Thank you, sir. We'll go to the next.
TNOA's help, we can do it. Thank you, Shruti, for that lightning talk, literally. So that like a rapid fire session.
Yeah.
Thank you, doctor.
Thank you.
So over to Dr. Satyan. Glaucoma, the silent thief, new drop, lasers, and MIGS.
Thank you, sir.
Yes.
Am I audible, sir?
Yes, sir. Yes, sir. We have another 15 minutes, sir.
Very clear, Satyan.
Very clear.
I'm not able to share.
Audible.
Not turned on. 1 minute, sir. I have a glitch.
It's also AM to here.
Screen share. Ayo.
Any problem,
Sorry.
Satya?
Sir, I'm not able to share the screen.
Okay. Over controlling the Anna, can
do
you
want-
make Dr. Satyan co-host? Or any IMA staff who's controlling the IT? Please make Dr. Satyan, Dr. Kaushal Ram as co-host.
I think Hannah madam is here. She could.
Because only the host can.
Kaushal, can you check your slides?
I'm not able to share also. Because I also have the
Okay.
host.
Madam, the
Has
sir
stopped,
co-host.
right? Shruti
Maybe.
has stopped sharing.
Who's, I
Yes,
think
sir. I had asked Hannah madam. So I think she'll be making Satyan sir and Kaushal Ram as the co-host now. Meanwhile, if you could share.
Okay, so before they do it, or I can finish my presentation if there's
Please,
anything.
sir. Please, sir.
Please go ahead.
Sir, Kaushal Ram sir has been made as co-host, sir.
Nirmal sir, you can. Sir, Satyan sir also has been made, sir. So you can try, sir. If you want.
able to, sir, able to see?
Not
Yes,
yet.
not yet.
Please share the slides, Satyan.
One minute, sir. Sorry.
Go ahead, Kaushal.
Sir, Nirmal sir, if you want to try.
Oh, I'll start then.
Yes, sir. Please, sir.
Please go ahead, Nirmal.
Are you able to see my screen?
Yes, sir.
Okay, thank you. And sorry for all these technical glitches. That gives me an opportunity to literally get crash in between the two other talks. So can you see this screen?
Yes, sir. Yes, sir. Please, sir.
So it's online. Maybe I'll ask start with a question to all our delegates here. So this is a wonderful painting and artwork by Van Gogh. These are two masterpieces. If you see both the art pictures, there is intense bright yellow in the picture. Can anybody put in the chat box what exactly and why his paintings or artworks are predominantly yellow based? Just wait for a few seconds. So this is actually called as Van Gogh's yellow. So whatever painting he draws, the cafe, the wheat fields, the sky, so even the sky would have a yellow tinge. So why is this world so yellow?
Colorblind.
Colorblind, okay. That's an interesting guesswork. But in 19th century, so this is why his artwork had yellow predominance. In 19th century, digitalis was widely used. It was used for everything. Went beyond treating the cardiac edema we know, including epilepsy, mania, asthma, and many other diseases. Vincent van Gogh was diagnosed as having epilepsy and mania. So he was said to have been prescribed digitalis by his attending physician. In fact, he drew up the portrait of his physician besides a foxglove plant where digitalis is derived. So at that time, digitalis plasma level controls were non-existent. So overdose was quite common. And Van Gogh suffered from a condition called xanthopsia, a distortion in color vision, in which objects appear more yellow than they truly are. And that was the reason why his pictures had predominantly very bright yellow, a usual sign of digitalis toxicity. So because a systemic drug quite literally colored a genius world, Van Gogh almost was certainly living with drug-induced yellow vision. So drugs change what the eyes see, and that is exactly where our story begins for the next 10 minutes or so. A systemic drug literally colored a genius world, and this is how there is an interaction between the drugs we use systemically, which can affect the eye, or the drops and drugs we use in ophthalmology affecting the systemic partner. So why the eye is our diagnostic window? MR sir gave a wonderful overview of updates on how eye can be a diagnostic window with reference to the systemic aspects. Because the aqueous, the corneal thickness, the neurodegenerative changes all can affect the eye and can manifest in many ways. So eye is indeed our diagnostic window because we can diagnose many neurological conditions with OCT now. Now oculomics is coming into the picture in a big way with OCT and few retinal diagnostic diagnostic imaging. We can diagnose Alzheimer's, Parkinson, and multiple sclerosis at a much earlier stage. Same way with diabetic kidney disease and other kidney ailments, and same way with coronary heart disease and major adverse cardiovascular events. So now ocular examination would become a biomarker soon with all this oculomics coming into the picture with the help of AI. So eye as a window, systemic medication and their ocular effects. So this is my topic because every eye examination can reveal medication-related ocular changes, and every eye prescription may carry systemic implications. So this was a study by Shedrick, Vernon, and Wilson, who identified that 70% of GPs admitted having uncertainties about ocular care or eye care. And 10% say eyes really scare me stiff because they don't want to touch any eye patients. So that is the anxiety and scare and fear among the practitioners with reference to eye conditions. But unfortunately, 80% prescribe some eye drops for their patients without exactly having a diagnosis. And 80% of them give antibiotics like Ciplox, Oflox, and gentamicin, and we see prolific prescriptions and antibiotic misuse, overuse, and abuse. And 50% of the non-specialist and general practitioners use steroid eye drops rampantly. And this is where this talk is very important. And rarely 30% refer to ophthalmologists for their for the patient's eye condition. And we see less than 25% referral for diabetic patients with retinopathy conditions. So general practitioners manage ophthalmic problem. They should also understand the therapeutic aspect. And we see a lot of geriatric patients with multiple disease, multiple drugs, and literally polypharmacy in the prescriptions. So basically, most of our ophthalmic patients are elderly. elderly and has so many comorbidities, and many of them have a list of anti-diabetic medication, antihypertensive, one or two statins, then blood thinners, and few other medications for their chronic ailments, and at least 3 to 4 vitamin supplements. So this is the reason why physicians and ophthalmologists should work in tandem, work together to ensure. 1 minute. Hello. So how should physicians communicate with each other, share updated diagnosis and medication list, flag high-risk drugs before procedures, and also clarify what to continue, stop, or monitor, and give a time frame for all medications. So if we have this communication between ophthalmologist and the other non-ophthalmic specialists and general physicians, it will help the patients in many ways. So this is a two-way traffic, ocular effects of systemic drugs and systemic effect of eye drops we need to consider. Life is when you open your eyes, and knowledge is when you see through them. So the next 10 minutes or so, I'll take you through this systemic medication and its influences on the eye. So the eye and the body share one circulation. So over 300 systemic drugs can damage ocular tissue, antimalarials, cardiac drugs, and anti-TB agents and steroids. And many changes are irreversible if missed early. Eye drops are absorbed into the bloodstream, same way, like particularly beta blockers like timolol, brimonidine have systemic side effects. They can trigger asthma or bradycardia. So how the traffic actually moves. So whether intravenous, intramuscular, subcutaneous, or dermal administration, it comes to the systemic circulation, reaches the choroid and retina, and through this, particularly drugs which have high lipid solubility has greater ocular penetration. And if there is low protein binding, a stronger ocular effect. And if there is ocular inflammation like uveitis, the blood ocular barrier is broken. So there are side effects that can affect the eye. So these are the systemic drugs that can harm the eye: antimalarials, cardiac drugs, anti-TB and antibiotics, and steroids and phenothiazines, which can affect the retinal pigment and cause certain changes. I'll just highlight some of the common ocular effect of systemic drugs. So first one is antimalarials, and the commonly given drug is the hydroxychloroquine or chloroquine. So hydroxychloroquine has a higher risk, particularly beyond this critical dosage, and while it can cause bullseye maculopathy. So this is the fundus picture which shows bullseye maculopathy, and this is a progressive retinal pigment epithelium atrophy. And chloroquine is again more toxic than hydroxychloroquine and cause more severe retinal damage and higher binding affinity. So you can see the retinal damage here, and this is the OCT picture showing parafoveal outer retinal atrophy. So what we need to do is, any physician prescribing this, you need to have a baseline fundus photo and a visual field examination. And OCT is now common with ophthalmologists. So a baseline ophthalmic examination is essential. And once you start treating the patient, annual screening if there is low risk. And if you're going to give for a long time, annual screening for all patients for 5 years. And Asian patients with renal disease, and elderly patients beyond 60 have a high risk. Same way with chloroquine. And the next one is the cardiac drug. Nowadays, the usage of digoxin and amiodarone has come down. So digoxin, I've already highlighted that yellow vision is a side effect. And usually these symptoms appear before the cardiac signs of digoxin toxicity. Amiodarone can cause corneal verticillata, usually harmless, and also cause visual field defect. and it is quite sight threatening if it involves the optic. So the next group of medication is anti-tuberculosis. Welcome, President Sridhar, sir.
Thank you, Nirmal. At last I am here.
Thank you. Hope the meeting went on well. So
Yeah, it has been fruitful. Sir, Mohan sir, vanakkam.
Vanakkam. We are waiting for you.
Yeah, sir, I'm here, very much here.
Sridhar, vanakkam.
You want me to address now?
Yes, sir, you can go ahead.
After the
I just started.
I don't want to interrupt. Nirmal.
Okay, sir, if you can.
Nirmal sir, you can finish it, sir. So that.
Okay. Okay, President. So anti-tuberculosis drugs are quite known to cause ophthalmic side effect. Particularly the optic nerve is under attack, and ethambutol is a commonly used drug. Beyond 15 milligrams, it is toxic. It can cause bilateral optic neuropathy, and early way to detect is having a Ishihara chart and look for red-green color defect. And if it is diagnosed earlier, it can be reversed. But please ensure if your patient is on ethambutol, have a monthly monitoring of visual acuity and color vision, and at least every 3 months visual field examination and fundus examination by an ophthalmologist. In case there is any visual change for patients on ethambutol, please stop the drug at once and refer urgently for ophthalmic opinion.
Sir, Frederick, by adding pyridoxine and neurobion, will it protect the eye?
I'll come back to you, sir. Let me finish. So we also heard about steroids. So corticosteroids in any form, any dosage can cause posterior subcapsular cataract, raised eye pressure. In certain patients, it can be high intraocular pressure called steroid responders. Steroid-induced glaucoma is quite common, and long-term steroid usage can also cause a retinal problem called central serous retinopathy. So any route, whether oral, inhalation, or nasal, or through skin, we have to be careful about using steroids in any dose. So ophthalmic examination is mandatory, particularly for topical conditions. Please desist from using steroids unless it is indicated. The next is the alpha blockers, which Dr. Mohan Rajan also mentioned. The floppy iris due to alpha blockers, commonly tamsulosin and Urimax, which relaxes the iris, and this becomes problematic in patients undergoing cataract surgery. So the iris billows and the pupil clamps down. It blocks the incision and creates a lot of problem for the surgeon as well as the patients. So we would usually stop the medicine for 7 to 10 days for the drug effect to go. And we use certain medications like Visco to take care of the iris billowing. And of course, the blue world, the blue tinted gold, the sildenafil. So mostly harmless color, but never ignore sudden vision loss in patients using this. Patient can have cyanopsia, sudden blurring of vision, and light sensitivity. So after usage, so this is usually reversible and settles as the drug effect wears off. And we also rarely see ischemic optic neuropathies and CSR in some of the patients using sildenafil. So we have to be careful about using just the tablet word or the blue pill. And now this is semaglutide era, the new GLP-1 drugs. So even though this usage has become more with the advent of various molecules related to semaglutide, one has to be careful about the visual effects. Particularly, it can cause non-arthritic ischemic optic neuropathy in some of the patients. And for diabetic patients, it can worsen the diabetic retinopathy. So whenever any physician or specialist starting patient on semaglutide, please take a baseline retinal checkup before giving the drug or continuing the drug. Anticoagulation, yes, we asked to stop the drug before eye surgery, cataract, glaucoma, or retinal surgery. So the general thumb rule is aspirin group of medication need not be stopped, particularly if the patient is going to be operated under subtenon or topical anesthesia. But for other forms of eye surgeries, glaucoma, retinal surgeries, or even anti-VEGF injection, the clopidogrel, procedural, warfarin, all these group of medication have to be stopped. So this is where we need to work together, ophthalmologists and other specialists, to ensure it is optimally conditioned, the drugs are optimized before doing the surgery for our patients. Anti-VEGF, a lot of injections forms have come now, and so nephrologists are fond of asking about, and nephrologists and cardiologists are very fond of this drug, creating a real scare in the mind of patients. But in indicated patients, many of these anti-VEGF is working only within the eye, and whatever risk, the clots, hypertension, and poor healing are theoretical. And so a lot of RCT meta-analysis has clearly told that there is no rise in heart attack, stroke, or increase in hypertension. But within 3 months of heart attack or any cardiac event, the use of anti-VEGF has to be properly controlled. And again, in pregnancy, patient with gestational diabetes, anti-VEGF is, we have to avoid anti-VEGF group of medications. So emergency drug-related referrals. So if in any case, if the patient complains of any visual symptoms or acute angle closure from use of topiramate or anticholinergics, we need to stop the medication and refer for ophthalmologist's opinion. So the first thing is stopping the medication and then taking the consultation and coordinate with the physician and the other specialists to ensure patient's drug condition is stopped and all the warning signs are taken care of. And there are few medications that can affect the whole body, particularly drugs, just eye drops can slow a heart, tighten a chest, or sedate a baby. So these are the three important events: cardiovascular, respiratory, and neurological events we have to be wary of in patients using certain group of eye medications. So it may be just one single drop, but this drop can enter the system through the tear duct drainage and rapidly get absorbed in the nasal mucosa and bloodstream and can cause real problems. So we have to be careful when patients are using timolol beta blockers, which can cause bradycardia, hypotension, heart block, and also reduce exercise tolerance. Obviously, timolol is contraindicated in patients with asthma and COPD. And so beta blockers, again, if you are, it used to be the drug of choice for glaucoma patients, but now with better medicines available, it is no more the drug of choice. But when they are taking beta blockers, you have to be aware of this respiratory problems and the cardiac events. And brimonidine can cause, particularly used in children, it can cause CNS depression, cause lethargy and drowsiness. So physicians have to be aware of this and ask for usage of eye drops in patients with these symptoms. So risk reduction is important. So you can advise your patients to do punctal occlusion. So after applying these drops, at least 2 or 3 minutes after each drop, close the eyelid and gently have a pressure over the nasolacrimal duct. So that will reduce the concentration or systemic absorption. So this is the drug which I already mentioned, and there are certain more drops like phenylephrine can cause blood pressure because we use this drug for dilatation in our OPD. And I've already told you about the steroid drops and the other medications like atropine. So same drop, bigger risk in children. So you have to be very careful in polypharmacy and usage of ophthalmic medication in vulnerable age group like children, elderly, and pregnancy and lactation. So these are some of the red flags when you think of drugs. When the color vision is fading on ethambutol, stop the drug and refer the same day. Same way, if patient is on timolol, if it's asthmatic or slow pulse in a glaucoma patient, you have to be aware of. I already told about topiramate induced acute angle closure and the yellow vision on digoxin. So drug monitoring is very, very important, whatever drug you prescribe. So high risk monitoring with reference to steroids, ethambutol, phenothiazines and interferons and hydroxychloroquine. And for other medications, yeah, annual checkup or 6 monthly checkup is necessary for all high-risk medications. And any patients who are given chronic topical medications for 6 monthly, there has to be a ophthalmic examination. So drug safety takeaways, prevention first, baseline ophthalmic examination is necessary for all this high-risk medication, and risk stratification is very important. We have to consider patient factors. Early detection is very important, and regular monitoring protocols have to be followed. So these are some of the take-home message: prevention first, and early detection is important. So one patient, one circulation, two-way it can affect. So every drug history is an eye history, and every eye drop is a systemic drug. So let us optimize this drug usage and be aware of this condition so that we avoid the risk factors and also the other acute side effects. Thank you so much for your patience here.
Wonderful, wonderful, Nirmal. Superb.
Thank you,
Excellent
sir.
presentation, Nirmal.
Thank you, sir. So now we have the president of IMA Tamil Nadu State Board, Dr. B. Sridhar, who himself is a ophthalmologist practicing at Karaikudi. He's been very active in IMA in all positions, and now he's in the highest chair as president of IMA Tamil Nadu State Board. I request Dr. Sridhar to address the delegates.
Good evening, Dr. Nirmal, and my special greetings to Dr. Mohan Rajan, what I can say, the guide and guru of many ophthalmologists in Tamil Nadu. I'm really delighted, not just as a president of the association, but as a fellow ophthalmologist, to be part of this webinar on this particular day of ophthalmology. And I'm very pleased to see the array of speakers, starting from Dr. Mohan Rajan through to Dr. Kavita Lakshmi, Dr. Kalpana Suresh, Dr. Shruti Nishant, Satyan, Koshal Ram, and Nirmal. I think all are doyens in their own specialities, doing excellent work in their own field. And it is the luck of the delegates today, whoever have attended this webinar. They have heard from some of the best brains of ophthalmology in Tamil Nadu. I'm very definite about that because I have moved with every one of them, and I've been always amazed at the interest, academic especially, academic interest they show in their day-to-day practice. Many of us see patients, even 50 to 60 patients per day, but few of us view it from an academic angle. But these scholars, faculty who have done the job today, they are people who not only attend to their professional work, but also has a academic eye on every case they have been seeing. Of interest will be those remarks by Nirmal, because I joined only in the last session about this ethambutol. I get regularly patients referred from physicians to rule out color vision issues where there is ATT, anti-tuberculosis treatment is being given with ethambutol as the main drug. And somebody asked whether it can be reversed with pyridoxine. I think that Chennai South Southern Keta, Sudharmati sir Keta. My answer, correct me, Nirmal, if I am wrong. If you detect it early, it can be reversed, not just with pyridoxine, just cessation of the drug itself is more than sufficient. But once the color vision loss is well established, I don't know, I don't think it can be reversed. And so that is it. And then people get referred to us who have been on long-term treatment of hydroxychloroquine, again for color vision testing. And diabetic people regularly get referred to us to rule out not only diabetic retinopathy, many of them have coexistent glaucoma as well. So these people need a thorough and sincere examination by the ophthalmologist. And that is where ophthalmology comes into play in the medical field. In pregnancy, there are two maternity institutions around my hospital. I regularly get patients in term pregnancy or in the late trimester with complaints of blurring of vision and rise of pressure, requesting for a fundus opinion. These are all very tricky. What is today a normal fundus, tomorrow may turn papillomatus tomorrow. So all these things, there is a Tamil proverb saying, Agathin Alagu Mugathil Theriyum, meaning that the well-being of the body is reflected on the look of the face. But let me say this way, whatever is in the body, most of it gets reflected in the eyes. Many of the major illnesses we can detect if you only know how to examine the eye bit by bit, part by part. If you know what you are looking for, what the mind does not know, the eyes do not see. So if you know what you are looking for, most of the illnesses you can get corroborative evidence with an examination of the eye. That is the significance of ophthalmology in the general field. Recently, I had a patient with transient blurring of vision, amaurosis fugax we call it. And on a deeper examination, we found out a carotid atheroma. You had almost gone in for a cerebral infarct. There was a hypertensive lesion in his mid-temporal region. He was a driver by profession. Almost got two VIPs into an accident just 3-4 days back. So that way again, eyes become very important in the detection of major illnesses. I'm very happy and to be a part of this session, though it is at the end of it. As for my work today, Nirmal, I'm very happy to inform you, all the delegates and members of IMA. Today we have signed a historical MOU with the prestigious Sri Ramachandra Medical College, Medical University, Srihar, the academic side, on an advanced hospital administration teaching program, a 1-year program for members of IMA, that to Nursing Home Board.
Superb, sir.
Initially, it will be at a state level. Thank you, Mohan. It will initially at the state level to be then taken over to across India. And this is just the beginning. There are more courses to come. We will be signing more MOUs because as doctors, we need to improve ourselves both in the administration and financial aspects. Our focus will be on administration and finance in future as far as academic programs are concerned. So with these words, I thank Dr. Nirmal for waiting for me so long. I thank Dr. Mohan Rajan for giving me this opportunity. Thank him for being here all through the session in spite of his busy schedule. I don't know how preoccupied he is with his practice at this hour of the day. Thank you, Mohan, for your affection to IMA and well done, IMA AMS.
Welcome,
Thank
welcome.
you. Thank you,
Sir,
Nirmal.
President sir, இன்னைக்கு ஒரே CME marathon section of the eye. So
Thank you, sir. Thank you very much, sir.
Hope you enjoyed it, sir. Sundaramurthy, sir, hope you enjoyed it.
Thank you, sir. Well done, sir.
Thank you very much, sir. Sridhar,
Thank you, sir. Shall we
the
get to
leading
the next?
light of IMA.
Yeah, nothing like that, sir. We have a lot more people, young thugs like Sendil Kumar, Nirmal Frederick, Anand Sokalingam. They are all doing very good academic work, sir.
Yes, sir.
We have a good generation to follow us.
We are blessed to have an ophthalmologist as the head of the IMA Tamil Nadu, and that too a person like you, who is known for your humility and simplicity.
The biggest happiness was when Dr. Kavita Lakshmi told me, now Dr. Nachiyar was very happy when she was told that I will be addressing the seminar tomorrow in a local seminar in Tambaram.
Yes, sir.
That is the best teacher can do to his student, to her student.
Absolutely, sir.
So
Absolutely.
Sridhar sir, you attended Hindustan College today for drug
Yes,
abuse.
sir. Drug abuse awareness
Very
program,
happy to see
sir.
you, sir. Very happy to see
Mr.
you.
Deepak Kaushik, Superintendent of Police of Narcotics Control Bureau, was the guest of honor. We all talked to the students. There was a good response, sir.
Excellent.
Thank you.
Satyan, sir, can you?
Thank you, President. Thank you for joining us in spite of your busy schedule.
Nirmal, it's a great honor for me to be with you all, guys.
Thank you, sir. And thank you for calling me young.
Thank you, Sridhar. Bye.
You're always young in mind. That's what is important.
Satyan's been waiting for a long time.
Definitely younger
Sir,
than me, Nirmal.
host is not allowing to
Younger
share.
than me.
No, sir, you are made the co-host, sir.
Not yet, sir.
Still,
Not yet.
Host is
Not
allowed
yet.
you.
right.
No.
Please send the.
Sir, I have sent a PPT already, sir.
Oh, really? Okay. Just give me a minute. Kaushal,
Nirmal, can I take leave, Nirmal? Please.
Thank you so much, sir. Sure.
Satyan, please forgive me.
Thank you, sir.
Sridhar, thank you.
All the best, sir.
Thank
We'll
you.
meet up soon, sir.
Thank you, sir,
Thank you,
for coming.
everybody.
Thank you for the
Thank you,
opportunity.
Sridhar, sir.
Thank you for
Pleasure
the
is mine, sir. Pleasure is mine. Thank you.
Thank you, Sridhar, sir. Thank you.
Thank you, sir. Thank you.
Sir,
Sir, able to download, sir? Nirmal, sir?
Not yet, Satyan.
Can I share, Nirmal, sir?
Try to share. Yours is there, Kaushal, sir. Yes. Finally.
Can I start?
Yes, sir. Please, sir.
Yes,
Yes,
please.
yes.
Okay, sir. First, I would like to thank our state president, Dr. Sridhar sir, for his kind words, and of course our Dr. Mohan Rajan sir, who has been very encouraging, and Dr. Nirmal sir, who is the chairman of IMA AMS Tamil Nadu, who has made sure that we are all there in this program. Thank you very much, Nirmal sir, and fellow ophthalmologist as well. So today I'll be talking on diabetic retinopathy 2026 screening, anti-VEGF, and what every specialist and physician should know. So we have gone for a long time, and almost 2/3 of the type 2 diabetics and all type 1 diabetics are expected to develop diabetic retinopathy over a period of time. And with advancing life and newer drugs.
Hello.
Hello?
Sir.
Yeah. With the advancing lifespan and newer drugs, am I audible?
Audible,
Yes, sir,
audible,
audible, sir.
Kaushal.
Audible.
Yes, sir. Please continue.
Audible.
Newer drugs every diabetic is a potential risk candidate for developing diabetic retinopathy. So, as ophthalmologists, general physicians, we all will be dealing them at some point or the other. So, diabetic statistics in India and have paralleled and mirrored the world statistics in a similar way. And studies, particularly the Madurai studies and Shankar Nethralaya studies, have clearly shown that the instance of DR is more in both urban as well as rural areas. And but there is something called the Asian phenotype. The Asians have a higher waist ratio, they have higher level of total and visceral fat, and they are known for insulin resistance. And we should be aware that systemic control is very important in the management of diabetic retinopathy. Estimating the HbA1c and controlling it is very important. UKPDS has also clearly demonstrated that tight blood sugar control is very important in the management of diabetic retinopathy. Treatment of coexisting renal disease is very important. Early detection of renal disease and treatment is very important in the co-management of diabetic retinopathy and the systemic profile of patients. Elevated serum lipids have to be addressed because there is a relationship between increasing level of serum lipids and the cholesterol deposition in the macula, which have been proved by Amod Gupta et al. In PGH Chandigarh when they have studied and shown the treatment of hyperlipidemia is very important in the management of diabetic retinopathy. And taking precedence, they used to use systemic drugs before treating the ocular macular edema as well. So when the today's talk is more about screening, so the conventional single photographic image is not enough. What we need is a 7-field photography. The single field photography is just for detection. So probably we need at least 3 images. And now with the era of telemedicine and the various softwares available in the market, the screening is very important. But what we are seeing is only the tip of the iceberg. What we are seeing is only we have so much of undetected disease which is happening in the population, which have been treated, which have been identified on a daily basis. And so screening is important. And now in the era of smartphone, there are a lot of devices. I have no financial interest on any of the devices, but I'll be talking about devices we use very commonly, which is the fundus on phone, and which is a very novel concept, and also the Forest imaging, which is developed by a Bangalore-based company. And both these images are slightly cost-effective. It's easier for physicians to use because as per the guidelines of diabetic retinopathy screening, the type 1 diabetic should be screened within 5 years, and type 2 diabetic should be screened at the time of diagnosis. And what we must understand that all diabetic patients need a annual eye checkup. And if the more recent in pregnancy, they should be examined because pregnancy causes exacerbation in diabetic retinopathy. So this is the photograph now in the modern era. We get a smartphone image and mostly non-dilated also, but there is a provision on the fundus on phone also to get other quadrants. So when we train optometrists and other people to screen, we should make them take pictures of at least around 3 to 4 quadrants. in detection of diabetic retinopathy. So there are numerous devices which are available, and most of these smartphones have got an AI platform also. And one big advantage is when we start using smartphones in the eye, we can detect cataract also, we can detect glaucoma, which is also a sight-threatening problem, along with diabetic retinopathy. So just a quick recap. This is the normal retina which we see. This what we see is the normal optic disc with a cup disc ratio and the retinal arteries and veins. And the focus should be on the macula, the area which is in the center, which is a pigmented area and the area concerned with vision. So as diabetic retinopathy progresses in the stages of mild, moderate, and severe non-proliferative retinopathy, we can easily see that the intensity of hemorrhages, the hard exudates, the macular edema increasing. And what we are seeing is in the final stage, in the case of severe or a very severe non-proliferative diabetic retinopathy, or we can pick them in the stage of a clinically significant macular edema when we have a photograph like this in which you have got a multiple hard exudates in the macula, or it can be a very small amount of macular edema as you see in the top photograph. But all these images are treatment and visually significant or sight-threatening retinopathy images which needs immediate attention. So normally what we see a clear vision, a diabetic might see like this, or he might see floaters or flashes, or sometimes when the photograph image can also see new vessels bleeding, new vessels on the retina with neovascular prawns and vitreous hemorrhage. So when patient presents at this stage, it's very important for us to refer them for timely pan-retinal laser photocoagulation, which has been the treatment of choice for diabetic retinopathy. So even today, much of the disease is detected too late even for effective laser surgery. So there is a big catch here. So we have to diagnose them. At the same time, we have to diagnose them at a stage of moderate or severe non-proliferative diabetic retinopathy, so that we can use our treatment, the arms, mainly the injections as well as the laser treatment, so that we don't want a sight-threatening retinopathy to happen. So how to do it? We have to screen all the diabetics. So with all these devices which are available in the market, because from conventionally, since the area of xenon arc laser, pan-retinal laser photocoagulation is the treatment of choice for proliferative diabetic retinopathy. So if you go laser spots like this, either a single spot or in patterns, in both the superior, inferior, and the superior quadrant of the retina, staged over 2 to 3 sessions, we have known time and again that diabetic retinopathy decreases, and and also the laser treated eyes do well even when we go for an injections, or as well as when we do a vitreoretinal surgery. So my talk will be incomplete without intravitreal injections, because now this has become very common, and I think it has to be used by almost all ophthalmologists in the management of diabetic retinopathy. In more so because these diabetic retinopathy patients also show an exacerbation after cataract surgery. So why do we need to give these injections in the eye? There is something called a blood ocular barrier. We know there is a blood aqueous barrier as well as the blood retinal barrier. So the systemic drugs reach very low concentration in the eye. So we are bypassing both these barriers and depositing this drug directly into the vitreous cavity, so that the drug immediately acts on the retina. So this is the rationale by giving this intravitreal injections. So these injections are given in our country in the operation theater or in the side room under strict aseptic precautions only, because through a needle which is inserted through the pars plana. So of late, there are a lot of injections. You have got the anti-VEGF, you have got bevacizumab, you have got ranibizumab, you have got all biosimilars now in the market, and we have got aflibercept, which is also an important agent, and not to forget the intravitreal steroid agents and the implants, the dexamethasone and the fluocinolone implants. All these agents can be used in the management of diabetic retinopathy, and they can be used in the operative setting after administration of the topical drops, antibiotic drugs, and administration of povidone iodine eye drops in the conjunctival sac. the same way as we do a cataract surgery. This is how we do in our country under strict aseptic precautions in the operation theater. There are very few centers which give in the office based in an Indian scenario. So the safe injection is to give a very small volume. And what is more important is to patch the eye for a few minutes or put a goggles for them and send them and call them the next day and telling them that if they have any signs of any drop in vision, they have to report to the ophthalmologist. And these drugs take at least 3 weeks or 4 weeks to have its effect. And most of these patients also need a repeat injections also. Not one or two, they need at least one injection at least for the first 3 months, and then based on subsequently based on the response. So we have to get a clear consent form, and now we are not using Avastin because all the biosimilars have been available in the market. The anti-VEGF biosimilars, particularly ranibizumab, has come in the market, and so we don't use intravitreal Avastin, which was one of the first drug which came into the market. So there was a survey done by the AAS on how intravitreal injections are being done in the country, and they found out that most of the patients have been assessed for cardiac and other risk factors. Most of the injections are done only in the operation theater under strict topical anesthesia, and very used by this, and all they follow the same protocol which they use for cataract surgery. And giving is very simple through the pars plana, 3.5 to 4 mm from the limbus. The injection is given directly into the vitreous cavity. So these are the drugs which are available in the market. The biosimilars are there. The cost of the injections have come down because of biosimilars, and monthly injections are easily can be a part of the treatment in present day era. Because the VEGF levels are dramatically increased in the retina in diabetic retinopathy. Targeting the VEGF with anti-VEGF is an important part of addressing the issue. So I will again tell about this the only single study, which is the DRCR, which we all should know, and in which they have clearly demonstrated that using intravitreal monthly injections, you can see the top two agents are they gave monthly injections of ranibizumab, and over a period of 2 years, they found that the eyes which received injection had a reasonable improvement, mostly a 3-letter improvement in the ETDRS chart compared to the other agents, compared to the arms which underwent only laser alone. So in the present day era, so it is laser along with intravitreal injections in the management of diabetic retinopathy and diabetic macular edema. But most important is using them repeatedly, at least for the first 3 months. So when the patient is immediately diagnosed with DME, one thing is we have to always look, as ophthalmologists, initially told we have to see everything. We have to see the optic disc because they might have an associated disc swelling also. It can be diabetic retinopathy, can be combined with a diabetic disc edema also. So this is the OCT image which is showing a diabetic macular edema, and immediately treated with monthly injections. You can see the diabetic macular edema resolving by the OCT and the patient's vision improving subsequently. So this is the way the diabetic macular edema is being managed, and the severity is just at that point of time. If they are having a proliferative diabetic retinopathy, we have to initiate PRP laser also to these patients over 2 sittings. So there is another situation in which if you see the diabetic macular edema is more, as in this case again, and the OCT again showing an edema, we can even use a steroid implant, and which can cause a reduction in edema, and which can be managed over a period of 3 months. And if there is an increase in edema, subsequently treat. So we should not forget the fact that laser is an important part of our armamentarium, and doing a standard PRP over 2 or 3 sessions causes dramatic resolution of proliferative diabetic retinopathy as well. So because the proliferative diabetic retinopathy and the macular edema goes hand in hand, so managing with lasers and injection simultaneously is very important. So the injections are effective, fast acting. Caution should be used only when the patient is having a stroke or an underlying cardiovascular disease. So we can use some other agents, or particularly a steroid implant for them.
Diabetic
So,
retinopathy, the
screening
leading
is a
cause of
very important
blindness in
part of
working
this
age adults and
part of the world.
increasingly prevalent
So,
as diabetes
screening is
spreads
very
around the
important.
globe.
So we got various
Detection of this
devices.
condition is essential
We have
to
got
prevent
a lot of people are
irreversible
doing
vision loss.
screening immediately.
Some
The
1 billion
patient
families need
is walking into the
screening every
clinic.
year.
Like the patients are going near, we do a photography on the arrival.
We need a
So that we need
That's why Orbis is pioneering the use of AI to screen
a lot of
patients with
devices are there.
diabetic retinopathy.
You've got the
Cybersight AI, built and
you've got the
operated
popcorn device.
in-house
You've
by
got the
Orbis, uses artificial
Remedio
intelligence
device.
to
You've got the
images at the back of the eye.
DRS imaging. All this are very effective in screening all the patients, so that we'll be able to detect patients with diabetic retinopathy.
It takes just seconds. Orbis is rolling
Not
out
only
this
that.
approach in low and middle income countries.
So this is a fundus of phone, and the fundus of own phone can also be used to identify and treat the patients and show them. Immediately you get an AI overlap on that. The AI is able to say the treatable lesions and able to detect them and treat them as well. So very easy to use these images for the patient once you present to the clinic. Easy to handle them, and we can be taken even in the systemic clinic. So the take-home message is every diabetic is a potential candidate for developing retinopathy. Laser, that is pan-retinal laser photocoagulation with anti-VEGF treatment, is the treatment of choice in proliferative diabetic retinopathy with diabetic macular edema. And systemic control is an important part of the management of diabetic retinopathy. And if we do all this, and in spite of it, it progresses, we have to do a vitreous surgery in these non-progressive cases. So that's what I'd like to convey. And thank you all for the patient hearing. And thanks once again, Nirmal sir, for having given this opportunity. Thank you so much, sir.
Yes, sir. Thank you, sir. That was an elaborate and excellent presentation, sir. So, Satyen, sir.
Sir, it is there,
Can
finally.
Finally, Satyen.
Finally.
Yeah.
Sir, able to see?
Yes.
Yes, sir. Yes, sir. Please, sir.
Here we are able to
Okay.
see.
Reserve the best for the last.
Nothing like that, sir. Nothing like that, sir. Big shots have spoken. Sir, thank you, Nirmal sir, and thank you, IMA team, for giving me this opportunity. I'm here to talk on glaucoma, the silent thief. I will discuss about glaucoma, how to diagnose it, drugs available, lasers and mix, as much short as possible. So glaucoma, as you know, 95 million people are affected worldwide, out of which 4.9 million people are blind because of glaucoma, which is the second most common cause of blindness worldwide. And in India, 12 million people are affected, out of which 1.2 million are blind due to glaucoma. Glaucoma causes irreversible blindness as against cataract, which can be cured. So glaucoma course, most of the time we end up seeing here where already half of the process of glaucoma are changes which are underlying changes in eye has happened already because of glaucoma. So detecting this at this stage and treating aggressively will prevent blindness and saving the sight for the rest of their life. So what are the types of glaucoma? It can be primary or secondary. Primary is idiopathic or and with unknown cause, mostly of genetic. It can be divided into open angle and angle closure. Open angle can be open angle glaucoma, normal tension and inflammatory, which can be open. And steroid response, as Sir Nirmal has said, use of steroids, whether in any form, oral, intravitreal or topical, can produce steroid responding glaucoma. In case of angle closure, acute angle closure and chronic angle closure, as Dr. Kavita said, most of the red eye presented to a physician in a urban or a semi-urban areas for headache and vomiting could be an acute angle closure glaucoma rather than some other related issues. So like GA problems. So apart from primary glaucoma, which has more of a genetic reason, secondary could be having some reasons in the eye. Can be a neovascular glaucoma following advanced diabetic retinopathy, central retinal vein occlusion, can be an exfoliative glaucoma, can be a pigmentary glaucoma, can be a post-uveitic glaucoma, can be a post-phacolytic or phacomorphic glaucoma. And you can also have a post-operative following a cataract extraction, following a corneal transplant, vitreoretinal surgery. It can be following trauma, malignant glaucoma, and iridocorneal endothelial syndrome. So managing glaucoma depends on what type of glaucoma it is, open angle or closed angle, which can be based on primary or secondary. Mostly in case of an open angle glaucoma, we always start with lowering the intraocular pressure with drops. And then you can use procedures like SLT to reduce the intraocular pressure. If nothing works, then you can proceed on to glaucoma surgery. In case of a closed angle variety or angle closure variety, the first thing you have to do is a laser peripheral lidectomy. Then lens extraction might play a role according to Eagle's study, and lowering in intraocular pressure with drops or glaucoma surgery. So the basic principles of managing glaucoma: first, establish a diagnosis, establish a baseline IOP, set a target IOP, initiate a treatment to reduce IOP to target IOP, and look for complaints and follow-up in the patient, which is very important. So establishing a diagnosis, comprehensive eye examination is very, very important in detecting glaucoma early. And any patients above the age of 40 years should be checked for intraocular pressure, eye pressure, and looked for glaucometer changes in the optic nerve. And slit-lamp background biomicroscopy, Goldman applanation tonometry, gonioscopy, preferably indentation and dynamic, indirect ophthalmoscopy, and stereoscopic examination of ophthalmic disc and optic disc and nerve fiber layer. So once you do an applanation tonometer to measure the IOP, the applanation should be preceded before the gonioscopy. So do the applanation gonioscopy, measure the intraocular pressure, and do an the gonioscopy to know whether the angle is open. And if the angles are open with raised pressures or normal pressures with optic nerve changes, then these are called open angle glaucoma. If the angles are closed or narrow or occludable, then these people are called as angle closure glaucoma, which can be divided into a primary angle closures as PACS, PAC, and PACG. And look for optic nerve changes. This is the normal optic nerve, and you can see the enlargement of the cup with increase in the cup disc ratio with a significant V-shaped retinal nerve fiber layer defect. And also look for optic disc hemorrhages, which are marginal, and which if somebody is on treatment, it indicates poor control. Or if somebody is not on treatment associated with enlarged cup, you have to suspect glaucoma. And once the applanation IOP is measured, gonioscopy is done, optic nerve is evaluated, you have to confirm all these changes through a array of tests like visual field. We have to correspond to the inferior RNA field effect should produce a superior scotoma, and this has to be corresponded with the objective way of measuring the retinal nerve fiber layer, loss of retinal nerve fiber layer. Then establish the baseline IOP. Only known causable and treatable factor is the intraocular pressure. One-time recording of IOP is misleading. Repeat intraocular pressure at variable time. And ideally, if you have an inpatient facility, doing a diurnal variation test is ideal over a period of 24 hours. Measure the corneal thickness to know the true intraocular pressure or the corrected intraocular pressure. Ideal corneal thickness is 545 microns. Thicker the cornea, the overestimation is the intraocular pressure. Thinner the cornea is underestimation. There is an algorithm to correlate based on the thickness of the cornea. Then set a target intraocular pressure. EMGTS study showed a 25% reduction in intraocular pressure reduces the progression of glaucoma by around 62% to 45%. Collaborative initial glaucoma study also recommends a reduction of around 35%. So the rule of thumb is if you see a milder early form of glaucoma, like when the mean deviation in the visual fields is less than 4 decibels, aim for 20% reduction. If it is between 4 to 12 decibels in your visual fields, then aim for 30% reduction. If it is more than 12 decibels of mean deviation in your visual fields, aim for 40% of reduction. So customization of target intraocular pressure, targeting the intraocular pressure, it depends on 3 things: the level of damage, life expectancy of the patient, and the baseline pressure at which the patient was diagnosed. If the damage is early, you can even aim for higher intraocular target pressures. shorter the lifespan. See, you need not be very aggressive in a patient with 60 or 70-year-old with mild to moderate glaucoma. You can set a higher target pressures. When you have a long life expectancy like 30-year-old or 40-year-old with advanced cupping, then you have to aim for a lower teen intraocular pressure. Then according to American Academy of Ophthalmology classification, milder, as I said, milder 20%, moderate 30%, and severe 35 to 40%. Then medical management of algorithm, the first choice is always a monotherapy. As Nirmal sir said, timolol has been substituted as a first-line monotherapy to a prostaglandin analog, as it has a lot of systemic side effects like bradycardia, bronchoconstriction, hypoglycemic unawareness, and all those. And in younger patients, you should avoid giving beta blockers because it can reduce lipido on all those things. So give a first choice monotherapy, aim for a sufficient IUP reduction, look for stable visual fields and optic nerve head, no side effects, continue it, and verify endpoints regularly. If the initial monotherapy is not working with insufficient IUP control, not a stable visual fields, with lot of contraindication and intolerance, then switch to a monotherapy again. Don't add medication for the second time, and repeat the same procedures. If the target IOP is not reached despite safety and stability, then go for a combined treatment. If even the combined treatment doesn't work, go for the laser management and followed by surgical. Surgical management can be the last way of managing intraocular pressure. So multiple drugs have come, starting from age-old pilocarpine to iobrim to beta-oxalol to timolol to brimonidine to combination of drugs. And the newer drugs are the Rho kinase inhibitors, which improves the conventional outflow. And one other drug is nitric oxide associated latanoprost, which also has both conventional and ilioschleral outflow increase. So there are a lot of newer drugs. You have to be very cautious in giving timolol in certain conditions. Avoid brimonidine in younger patients and older patients. It can produce drowsiness. And somebody is a smoker, avoid brimonidine in these cases. When somebody has a compromised cornea, then avoid dorzolamide. When somebody has a sulfa allergy, and you have to warn them about altered taste. And prostaglandins are relatively safer systemically, but when somebody is pregnant, when they are planning for a family way, then avoid prostaglandin in these patients, as they are known to cause very rarely abortions. So evolution of bottling. Bottling also has changed along with the invention of newer drugs. Lot of preservative-free medications have come in the market with lot of good delivery system, like third generation ABAC to Nuvilia to ophthalmic squeeze dispenser. So coming to lasers in glaucoma, we will talk about therapeutic uses of lasers in glaucoma. There are mainly three uses. One is a peripheral iridectomy, which is primarily used for patients with angle closure disease, whether it is angle closure suspect, angle closure, and angle closure glaucoma. Whichever way the type of angle closure disease it is, primary peripheral iridectomy is the way forward. First thing to be done is the peripheral iridectomy, followed by either medical management or surgical management. Then previously we were using organ laser trabeculoplasty, which were refined, and now it is a selective laser trabeculoplasty. Why selective laser trabeculoplasty? Because organ laser uses an organ laser which produces heat associated with inflammation, and the inflammation is relatively higher. Even though the IOP reduction is much more similar, whereas in case of a selective laser trabeculoplasty, it uses an Nd:YAG laser. It specifically focuses on melanin containing trabecular cells because only those cells are damaged. It enlarges the pores of the trabecular network, increases the outflow, thereby reducing the intraocular pressure by around 20 to 30%, which is the preferred way of laser trabeculoplasty. You can, the effect of these lasers lasts for almost a year or two. And if you feel that the effect is waning, then you can even repeat in a different quadrant. So coming to the surgical way, the well-known time-tested procedure is the trabeculectomy, where you create a path for the aqueous to come from the antechamber to the subconjugal space where the veins and the lymphatics absorb those excess fluid, which is coming to the subclavicular space and reducing the intraocular pressure. Then came the mix, which is a minimally invasive glaucoma surgery. It depends on where they are placed to improve the conventional outflow or the epioscleral outflow. The mix with implants, the Zen implant Hydrus microstent, which was recently launched by Alcon, iStent inject and iStent implant were the implants which are implanted in the angle of the antechamber through using a direct gonio lenses through a port in the cornea, and you reach the antechamber, inject those implants into the angle of the antechamber so that it directly drains the aqueous into the collector channels and thereby reducing the intraocular pressure. And these can be either one or two can be injected, or it can have a multiple implants to reduce based on the level of intraocular pressure at the starting the treatment. Then you can also have an angle-based mix procedures like GAT, where gonio-assisted transilluminal trabeculectomy, or trabeculotome, which removes the pigmentotrabecular meshwork, anterior layer of the pigmentotrabecular meshwork, or KDB blades, which can de-roof the Schlemm's canal. So decision making, anybody with less than 50 years, angle procedures or implants can be used, but angle procedures should be avoided. But ideally, above the age of 50 years, when somebody has an ocular hypertension without having an optic disc changes, then you can either, if they have an associated cataract surgery, you can do an early cataract surgery or a cataract surgery with plus or minus mix depending on your skill. Whereas in case of mild to moderate glaucoma, you can do an early cataract surgery or cataract surgery with mix. And mix are generally used in patients who have mild to moderate form of glaucoma. Better to avoid in case of an advanced glaucoma, where risk of the implants functioning in a better way is very less, and elevated IOP with moderate to severe damage to the optic nerve and visual fields. Avoid all those mix and go for a cataract surgery with or without trabeculectomy. And in case of a very advanced surgery where you think about wipeout phenomena, you can even think about a tube stent. Then how these mix are decided based on the nature of the collector system. If the collector system is intact, which where you want to enhance the outflow with intact collector system, then you can try GAT, KDB, trabeculectome, iStent. When the collector system is atrophic, then you can think about trabeculectomy or a tube stent procedure, a supraocular bypass, Zen implant, etc. And if you want to reduce the inflow, if you want to reduce the production of aqueous, then you can use an endo laser like endo laser cyclophotocoagulation or cryocyclophotocoagulation. I can even use a newer one like called micropulse cyclophotocoagulation. Thank you. Thank you for the opportunity.
Hello. Sir, that was an excellent presentation, sir, as usual. Do you have time for another 6 or 7 questions, sir? There are some questions in the chat box, sir. Nirmal, sir?
We can take some of the questions.
Yes, sir. First question probably we'll ask Satyan, sir, itself. Sir, what are the long-term side effects of bimatoprost, systemic side effects of bimatoprost, 0.01%?
Sir, generally I have not seen much of a systemic side effects of bimatoprost except for a local side effects where they will have a periocular pigmentation, growth of eyelashes, loss of orbital fat when they use it for a longer period of time. Then the patients will have a loss of periorbital fat with eye going in. These are the local side effects, not much of a systemic side effects.
Thank you, sir. Sir, Nirmal, sir, is stem cell therapy the future? That's a question.
Stem cell therapy we are already using in ophthalmology. Stem cell transplant for pterygium and limbal stem cell deficiencies for after chemical injuries. So it is already in vogue. So there are new regenerative medicines coming up in many other specialties and also in eye care. So definitely there is not only a present but also future for exciting research with stem cell therapy.
Okay. Sir, question, sir.
Yeah. I saw the
Role of anti-VEGF in NPDR progression. What is the role, sir?
தேங்க்யூ செந்தில். அதனால இவ்வளோ இன்டெலிஜென்ட்டாக நம்ம கேட்டிருக்காங்க கொஸ்டினை. இஸ் ஆன்டிவெஜெஃப் யூஸ்ஃபுல் இன் நான் ப்ராலிஃபரேட்டிவ் டயபெட்டிக் ரெட்டினோபதி? ஸோ இப்போ வந்து த ஃபியூச்சர் ஆஃப் கொஸ்டின் வந்து இதுதான். பிகாஸ் தட் இஸ் அ ஸ்பெசிஃபிக் ஸ்டடி, ஒரு பேனோராமா ஸ்டடின்னு ஒன்று வந்திருக்கு. தே ஆர் சஜஸ்டிங் anti-VEGF for moderate and severe NPDR cases. So
even without macular edema.
Without macular edema. Without
macular edema. Okay.
So இது வந்து interesting because they have the study has happened, sir. In the study வச்சு a lot of trials are going to happen. NPDRல anti-VEGF கொடுத்தா ஒர்க் ஆகுமா அப்படின்னு they have proved it is effective. But in a gray zone, and the moderate to severe NPDR, definitely, but single injection will not help. Again,
multiple injections,
multiple 3 loading doses, and subsequently, that it is going to. I think this is going to happen in the near future. I think because we are going to.
No, this is a huge study by DRCR Neil Bristler. You must be knowing better than me. So he says you cannot. You can avoid completely PRP. Don't do PRP for all these patients. Keep on giving anti-VEGFs every month for these patients. So I don't think it's practical, and also the cost because PRP says will reduce the field of vision and all those things.
Okay.
So, but anyway, it's very controversial. Yeah.
It's very controversial, but somebody has brought out in this forum. I'm really happy, sir. Actually.
Yeah. Correct. Absolutely.
Sendil sir, that question was. Despite normal glaucoma workup, somebody is on bimatoprost. Is it worth continuing? I think.
No, actually, the second part is whether bimatoprost long-term in the long-term cause systemic side effects.
Yeah, it doesn't produce unless if the patient is planning for a family way or pregnant or something like that, or if the normal glaucoma workup, if the glaucoma workup is normal, then better to stop the medication, look for the baseline intraocular pressure, and then decide.
They have mentioned that there is an asymmetry. They had mentioned there is an asymmetry, sir. We don't know whether it's more than 0.2 or not. Probably would have started. So that's why it's the second part only, sir.
If Dr. Satish is there, he can maybe unmute and ask the question. Maybe rephrase this question so that we can answer it in a better way.
Can we go to the next question, sir?
Yes, sir.
If it's not there. So what is the use of blue filter glasses in myopia and dry eye? Role of blue filters?
I think Shruti is not
Sir,
there.
I can answer. Dry eye and myopia no confuse it. Dry eye speaker ka sir, actually, animal studies have shown that blue filter in fact blue light is beneficial in children.
Blue light only, madam. The question was
blue light. Yeah. But that was only in animal studies. Now almost several human studies have now proven that red light in fact in that 680 nanometers is really helpful in myopia progression. In fact, it reverses also the axial length to a certain extent. Andalavukku effective in Ramadri, there are a lot of good studies. But because that involves some intervention, so because you're throwing the light in the child's eye for 3 minutes a day, considering it as an invasive kind of an intervention, not much of take-up has been there, and still in the research phase. In India, it is not yet available. In East Asia, several countries have it, and they are using it regularly. So red light, in fact, has a beneficial effect, sir.
Thank you, madam.
Thank you.
What is the ideal viewing distance for laptop?
So usually I ask children to extend their arms fully and at the edge of the fingers is where the laptop should be placed. This is an easy indicator for for bigger screens. Usually we take the inches of the screen. For example, if it is a 32-inch TV, into 2 will be the distance at which the child should be seated. So maybe 64 inches away from the screen, the child minimum distance at which the child should be seated, sir. It's a recommended distance.
And also, I think, Shruti, you should mention that bigger the better.
Yes, sir, 100%.
Yeah,
Bigger
smaller,
the
for
better.
example, iPad, tab, and phones will have worsening effect on the myopia. So I think bigger the desktop or even connecting it to the TV, to the Chromecast, it will be even better for the patient.
Yes, sir. So usually we recommend connecting a HDMI port
yeah,
to the
Chromecast.
TV and then use a Bluetooth wireless keyboard and a mouse. That is the usual recommended, sir.
The eyes have to diverge instead of converging.
Yes, sir. Yes, sir. Mohan sir said it very rightly, sir. That is the best.
Dr. Kavita Lakshmi madam, there is one more question. Laser versus spectacles advantages.
Pardon? Laser?
Versus spectacles for myopia. Advantages. What are the advantages and disadvantages?
Yeah. So laser, myopia correction spectacles will actually minimize and see the images. So the image which the person normally sees, he sees only a minimized image. So following laser, he will have a better, wider field of vision because the spectacles is not going to restrict him. And also you see the normal sized image. This is one of the biggest advantage. And another thing, if it will not reduce his day-to-day activities, or if he's trying to go in for some kind of a sporting activities, or he follows some hobbies or passion. So it will not basically restrict him. And during COVID time, we all realized that wearing spectacles is such a big nuisance because it really fogs when you wear a mask. And similarly, when you get out of the car or come out of a AC room, you know how it gets fogged. So these are some of the advantages. Otherwise, it is the option of the patient. Go for the laser, or if he doesn't want glasses, he can definitely go for laser.
Okay. Dr. Kalpana madam. So what is the best drug to use in an anesthetized patient? Teardrops or antibiotic ointment or tear substitute ointments? This is the question. Probably they wanted to know whether for it dry eye, I assume.
It depends upon how long. That is, they mean
The
during
long term.
anesthesia procedure.
No. The question it is written as in the long term. Probably not during the procedure. Probably some comatose patient or
Post-operatively or in the ICU.
Yeah.
See, if the eye is quiet and there is no signs of inflammation or congestion, you can apply gel ointments, like without preservatives, and keep the lids taped if there is a risk of exposure keratitis. Suppose if the eye shows some signs of inflammation, it's better to use antibiotic ointment. Otherwise, if it is accessible, HPNC gel preparations are there, ointment forms, lacquer gel or something like that. That we can apply liberally and do the taping of lids to protect the cornea, basically.
Thank you, madam. Sir, Mohan Rajan, sir.
Yes, sir.
When to stop clopidogrel before a surgery? This is one question. Because in your
for cataract surgeries, we don't stop.
Yeah, you told that, sir. So anything else you want to add?
For vitrectomy, vitrectomy and other glaucoma, anti-glaucoma surgery, we stopped 5 days back.
5 days.
Okay.
5 days before.
Okay. When to restart, sir?
Next day you can start. Next day after the surgery you can start. Unless otherwise the patient is posted for the other eye surgery or something like that. Okay?
Thank you.
Sir. And there was one question regarding the onset of the diabetic retinopathy and the nephropathy. So, lag period. So, normally what happens is when you diagnose diabetes, the onset of diabetic retinopathy is about 5 to 10 years from the onset of diabetes. But unfortunately, nobody knows when it started. So, he may come for a routine examination, and many times, we have found out diabetes on seeing the retina also. So, so I think that's one thing. Second thing is there's something called metabolic memory. I'm sure Kosal Ram would have, I don't know whether he mentioned that. The metabolic memory is something which is very, very important. What is this metabolic memory? The first 5 years, okay, of your diabetes control, if it's very tight, okay, the next 5 years, even if it's not tight or whatever it is, okay, there's a possibility that you can develop retinopathy, nephropathy, neuropathy, or all end organ problems. Okay, but the first year, 5 years or 10 years, if it is very tight control, then the next 10 years, even if it's not under control, you may not develop retinopathy or nephropathy. So this is something which is very, very important. So always make sure diabetology, that is the reason why we are having this IMA meeting also. Make sure that the diabetes is controlled right from the beginning and the first 5 years or 10 years or whatever it is. You have to have very tight control of a diabetes and associated factors like hypertension, dyslipidemia, anemia, and kidney functions, everything. So if they are very tight control, the next 5 to 10 years, even if it's not under control, but many patients come and ask me when they have advanced diabetic retinopathy, I have got very good control now. But if you look back at the history very, very first 5 years, the HbA1c would have been 10, 11, 12, something like that. And that's the reason why they have developed diabetic retinopathy later. This is a message I want to give so that because other physicians and diabetologists are also online.
Sir, a very important point, sir. நீங்க சொன்னது very well said. In the moderate to severe NPDR, they are presenting complete profile of doing a renal profile, lipid profile is very important. Referring them to a physician, so that is the point when we can arrest the ocular disease also, and their systemic disease can also be identified and treated. So that we have to convey to the physicians and refer them to the physicians. And உங்களோட பிரசன்டேஷன்ல எல்லா இமேஜஸும் ரொம்ப நல்லா இருந்தது. Which device was it, sir?
Clarus.
Clarus, okay.
Clarus. You know that I have got we have John Leo with us.
Okay.
And we have got, John Leo, no, who's he's got the highest number of American Academy Awards in the yeah. And we have got the maximum, we are on the cover page of the Retina Journal. So we have got very award-winning photographs. And we have got it's really great to have such images. Kalpana must be knowing about him. Yeah.
So one more question was asked while during Dr. Nirmal's presentation. Will pyridoxine be helpful? I think pyridoxine is used only for INH related
INH related. The pyridoxine
basic deficiency, right?
or not the ethambutol.
It's a combination medicine along with INH and pyridoxine. It is available. So previously, all neuropathies were thought to be due to pyridoxine deficiency.
Basics deficiency.
So I think now it is not given up with the new ATT in force.
And it has no role with ethambutol toxicity, right?
Yes, not for ethambutol.
So what I have done is a few cases, and we're trying to also publish this. Few cases of ethambutol toxicity I have given even with the consent from the pulmonologist, IV methylprednisolone. Okay, and you'll be surprised. From 3/60, one patient improved to 624 after the IV methylprednisolone and the oral steroids for it. Just like any other optic neuropathy, ischemic optic neuropathy, non-arthritic AON, all these, we try to do this because some sort of a toxic environment, this thing is there, element is there, which you can take care. Of course, we need to get the clearance from the pulmonologist before you start these patients on IV methylprednisolone followed by oral steroids, along with the neurobion B1, B6, B12.
Yes, sir. So basically, there are three components: ischemic, inflammatory, and degenerative. So if it is due to ischemia and inflammatory, steroids will help. But if it is due to degenerative and detected in the later part, steroids may not help.
Yeah, we can. Nothing wrong in trying. That's what I'm telling.
Yes.
Yeah. Yeah.
So any more questions?
Sir, there is a question. Do anti-glaucoma drops to be continued for lifetime if started for isolated raised IOP without any abnormality. That has to be stopped, need to be reassessed. If there is no obvious optic nerve changes, when optic nerve is normal, an isolated raised IOP, the drug should not be continued for lifetime. We have to answer that.
Yes.
I know many times, Satyan, which is
Yes, sir.
I know it's a very basic thing, but please, because many times, I have seen many patients with the raised IOP treated elsewhere, but the problem is they don't see the pachymetry. And if you look at the pachymetry, it'll be 580, 590, 600. And that's
Yes,
the
sir.
reason why they have 24, 25 and all that. Absolutely normal discs and without any problem at all. Normal fields, everything. So once you do the pachymetry, I think correction factor, all these patients become normal. That's all.
Yes.
Yeah. The
Sir,
pachymetry is very important.
even with an adequate 545 micron corneal thickness with 24, 25, up to 26, we need not treat, sir.
Absolutely.
The OSTS study says only when you have 26 with thin cornea, relevant family history, and all those things, you carry a risk of even that only 18%. So we need not be so aggressive in treating all these 24, 25.
Yeah, that's right.
Yes, sir.
The pachymetry is something which is very, very important. You need to take that always.
Yes,
Yeah.
sir. Yes.
Okay,
Thank
so
you,
if we
sir.
have exhausted the questions, we'll go back to the chairperson and co-chairperson for the final comments before the vote of thanks.
So that was an excellent presentation from all the speakers, keeping in mind the need of the audience, sir. And many congratulations to Dr. Nirmal sir and Dr. Sendil Kumar Pollachi for organizing such a wonderful AMS meeting. And you had made it tough for the people who are going to take it from you, sir, actually. So you had kept the bar so high. Thank you, sir. Thank you for organizing for such a nice meeting, sir. And over to Dr. Tangveli, sir, please.
Everybody for staying till the end. Mohan, you spent a lot of time with us. Thank you very much. Thank the presenters and the members for the overview of ophthalmology. Just a few points I'd like to add what I've been listening to. We as ophthalmologists brush through how to correlate eye signs with the systemic diseases. Redness is not to be taken for granted. Could be the tip of an iceberg. Preterm babies and babies weighing less than 1,500 grams need a dilated fundus examination to rule out retinopathy of prematurity. We are seeing very fast lifestyle changes. Don't forget how the gadgets affect our eyes. When you meet a child wearing a myopic glass, don't forget there are modalities to decrease the progression of myopia. Increasing outdoor activities, decreasing screen time are very useful. You can suggest them to your patients. Another thing is which we have not spoken about is I've been associated with Shankara, where with Dr. J.K. Reddy. Many of the burns patients, they lose their vision just because the corneal surgeon is not called to the first week, first few days. If the corneal surgeon can see them and an amniotic membrane, the wound is covered with amniotic membrane in the eye, they recover 100%. That is the proof which I've seen literally been done. So any burns case, I think we can approach an ophthalmologist, especially a corneal surgeon. Someone with a headache, don't forget acute angle closure glaucoma. Don't treat it as a gastritis. In an unconscious patient, never forget close the eyelids. In a diabetic patients, whenever you see a diabetic patient, you don't know when he has got diabetes, so suggest that you see an ophthalmologist to save a vision. And thanks everybody for this opportunity to chair this session. Thank Nirmal and the organizers, especially the Pollachi IME team, for giving us this opportunity, and for all the presenters. Thank you very much, Nirmal.
Thank you so much, sir. Thank you, Mohan sir. So now we go on to the official vote of thanks. I invite Dr. Mohammad Ibrahim, Joint Secretary AMS, to deliver the vote of thanks. If Sendil is around.
Thank you very much, Nimal.
Thank you so much, sir. Thanks for
very beautiful
with us for the last 3.5 hours.
Absolutely.
Till the end,
My
Mohan.
students also were there.
Thank you, sir. Thank you, sir. This is Dr. Ibrahim, Joint Secretary, IMA TNSB AMS. On behalf of the IMA TNSB AMS team, I thank all the delegates and the speakers. So all the speakers, Dr. Mohan Raj sir, Dr. Kavita Lakshmi, Dr. Kalpana Suresh, Dr. Shruti, Dr. Satyan and Dr. Koshal Ram, and our own AMS Chairman, Dr. Nirmal Frederick. They had a wonderful discussion and deliberations on various topics of ophthalmology. The highlight is many of the spectators, delegates were non-ophthalmologists here. There were pediatricians, general practitioners, even anesthetist was there. So the questions, in fact, one anesthetist only asked how to cover the eye during long procedures, because during long surgeries, we have to cover the eye with some eye ointment. So it was a wonderful discussion, which is very much useful for the day-to-day clinical practice. And special thanks to the chairman, Dr. Thangaveli sir, for sharing the words of wisdom finally, and also the co-chairman, Dr. B. Madhavan sir, and the convener, Dr. J. Sendil Kumar sir. The discussions went excellently, and this is in fact the third day of our 5-day marathon Amscon West Zone 2026. So we have 2 more days. So tomorrow is day 4. So the topic is on imaging and oncology, preferably on breast cancer management. And day 5 is a hybrid mode happening in Pollachi again. So that will be on plastic surgery. So hope to meet you tomorrow at 3 p.m. and join using the Zoom link tomorrow. Thank you all once again. Thank you.
Thank you, Ibrahim.
Thank you, Ibrahim.
Thank you, all speakers.
Thank you.
For accepting
Thank you
our
all. Thank you, Nirmal.
Thank you, everybody.
Thank you, sir. Thank you all.
Thank you.
Thank you, Mohan Rajan sir. Thangaveli sir.
Koshal.
Thank you, sir.
Thangaveli sir.
Thank
Thank
you.
you.
Thank you,
Thank
Mohan
you.
Rajan sir. Thank you, Satyan. Thank you,
Thanks a lot. Thank you so much.
Thank you.
Koshal. Thank you.
Thank you, Kalpana
sir.
madam. Thank you, Kavita madam.
Thank you all. Thanks, Nirmal.
Kalpana.
Thank you.
See you all in
Thank you, sir.
Coimbatore.
All the speakers.
See you all.
Thank you,
See you
sir.
all. See you all in Coimbatore.
Yes, sir. Yes, sir.
Yes.
Mohan, see you in Coimbatore.
Absolutely.
Thank you. Thank you.
Bye.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir. Thank you.